this Synergy 24 webinar on the topic Endometrium Decoded. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGY Society. She is Founder-President of ISOBAP Chapter of Bhopal. She is National Executive Member of ISAR. She is Joint Secretary cum Joint Treasurer of MPIAG, and she is Coordinator of Fox Infertility Committee. She is also convener of the Synergy webinar, and she was also the convener in the past of Perfection series and Symbiosis series. Over to Dr. Monica Singh.
Thank you, Dr. Vishal. And thank you to Intas Pharma for this academic support they have offered us over the years to our academic series. So today I am very happy to announce the 24th episode of the Synergy Club, which is in association with Firozabad, Ghaziabad, Gorakhpur, Jaunpur, Mathura, and Ratlam OBGY societies. It is with because of our collaboration with Foxy Societies that we are able to apply to ICOG for our points. So this time our webinar has been awarded 3 points by ICOG, and we are very happy to announce this to our audience. Today is 14th of February, popularly known as Valentine's Day, and also a very pious day for all of us because it is Mahashivratri. But what more gratitude and our offerings to God in the form of academics are the biggest which we can offer to God Almighty. So with this, we start our program on endometrium decoded. Endometrium is an enigmatic tissue. And everything begins and ends with endometrium as far as OBGYN specialists are concerned. I coined the term decoded because we are decoding it. Coding is a very, contemporary term. There are coding experts, but as far as we are concerned, endometrium is a tissue with lots of genetic environment in it, receptors and programming going on in the very dynamic and rapidly multiplying cells of the
Has she lost network?
Yes, Monica Singh madam must have lost network actually.
She is decoding network.
Yes.
She is there, but I think
I think she's lost network because we can see her, but the screen is, it's frozen.
Yes.
just wait 2 minutes. She will be back, I think.
Yes.
She's rejoined.
Okay.
She is there. We can't hear you, Dr. Monica. We are not able to hear you.
Ma'am, you are on mute. Just unmute your mic.
Hello.
Yes, ma'am.
Yes.
Now
Yes,
it's okay.
ma'am,
I'm
no
so
worries.
some construction going on in my house, so the internet just went off. So I'm on now hotspot. So excuse me for this interruption. We were talking about endometrium, and we have got stalwart speakers today to speak on endometrium. So let us proceed with our program by first welcoming our dignitaries. They have wealth of experience. And before we introduce our chief guest, our guests of honor and special guests, just a line about the talks which are lined up today. From 5:30 to 6:15 p.m., we have got Dr. Supriya Seshadri speaking on the differential diagnosis of a thick endometrium on USG. She is a speaker which many people are eagerly looking forward to listen to, madam. And we are fortunate to have her as a keynote speaker today. Next, we have got the current FIGO staging of endometrial carcinoma, a practical overview by renowned Dr. Bhagyalakshmi Nayak, madam from Cuttack. And then we have a very Madam has given us AITA guidelines, and she'll be displaying images on the screen, and she'll be asking panelists as to and what strategy they. That's just a short overview of the program. And now I formally extend my warmest welcome to our respected chief guest for the evening, Dr. Sarita Bhalerao, ma'am. Madam, we are honored to have you on this platform. Madam is Vice Chairperson-elect of the Indian College of Obstetricians and Gynecologists. She has held the various posts in ICOG and also has been the chapter secretary of Mumbai Indian Menopause Society, president of the Association of Medical Women in India, Mumbai branch,
कैसे होगा
quiz committee chair of FOXI, governing council member of
ज्वाइन ऑडियो
ICOG,
बाई
the
कंप्यूटर
president of prestigious Mumbai OBGY Society in the years 21 to 22, and joint secretary of FOXI in 2017. We know what a keen academician Madam is, and we look forward to Madam's blessings for this program.
Thank you very much, Dr. Monica, for inviting me and for that very, very elaborate introduction. And I'd really like to congratulate Dr. Monica Singh and Dr. Randi Singh for this whole series and the tremendous academic work that they are doing. It's a pleasure to share the platform with Dr. Neeraj Jadhav and Dr. Rajendra Nagarkatti and so many other stalwarts. I think that the topics have been very carefully chosen, and it's going to be a pleasure to listen to Dr. Bhagya Lakshmi and also Dr. Sheshadri, and also a very, very interactive panel on endometrium. I think you've really chosen a very nice topic, and I wish you all the very best for this webinar and also for the webinars to come. Thank you.
Thank you, Sarita ma'am. Thank you.
Thank you so much, madam, for your gracious presence and your kind words of blessings. Now, I would like to invite our guests of honor for the evening.
दोबारा करें
Dr. Dr. Arun Naik, sir, is not joined till now. Dr. Purva, can you give sir a call, please? And Dr. Neeraj Jadhav is there with us. Dr. Neeraj Jadhav, we welcome as guest of honor today. Sir has contested a very closely competed vice president election of FOXI recently and has emerged as a clear-cut winner like always. So, sir is vice president-elect of FOXI 2027. All the best for your tenure, sir. And during his tenure as chair, Sexual Medicine and Cosmetic Andrology Committee of FOXI, as well as IAS RM, sir has been held multiple academic activities all over the country with various societies in which all of us participated, and we know how committed he has been to this subject. So he chaired the Sexual Medicine Committee of FOXI 20 to 23. We have witnessed the growth and the way this committee has come forward. There were certain it was like at the back, this committee many years back, but now everybody wants to learn about sexual medicine and see what an impact they can make in their patients' lives by having knowledge of this important subject. Sir has also been the past president of Rajkot OBGY Society, always a supporter of our academic activities, a very warmly welcome guest in Bhopal. So Neeraj sir, the stage is all yours.
Thank you, Monica, for inviting me for this very prestigious series you are doing as a guest of honor. So my greetings to Sarita ji, Bhagya Lakshmi, I can see Dr. Manju Singh, Dr. Saili, Dr. Upma, and everyone here on the webinar. So at the outset, I would like to congratulate Monica and Randir for their great success in the ISAR election. So congratulations from my side, winning the for both of you. And I can see that the topic for today is very well chosen. And I forget Nagarkati is also here. Hi Nagarkati, how are you?
Hello, sir.
Yeah. So you have chosen very well topic of endometrium because generally as a gynecologist, we are so many dilemma when it comes to endometrial problem. What is the proper thickness? When should we intervene when there is a some thickness is there? So I'm sure that after today's webinar, so many queries of our gynec friends will be solved. So congratulations to you for choosing this topic for today's webinar. And I wish best of you for your future endeavor also. I know you are going to contest for the Foxy committee. So I full support to you and I'm sure you will be the winner for that committee. Thank you.
Thank you, Neeraj, sir. Thank you.
Thank, thank you so much, Sir Neeraj, sir. And now I would like to welcome our special guest for the evening. Dr. M.B. Bellard, sir, is with us. And sir, we welcome you. Sir is the Dean of the Karnataka College of Obstetrics and Gynecology. And I would also like to share that sir has got a very good sense of humor. So, I mean, I remember during the Sampurna conference, he kept all of us laughing for minimum 30 minutes continuously. So, sir, you have a very very vibrant presence in any meeting, and a sense of humor is always the something which is an asset to a person's personality. We also congratulate Mrityunjay sir for his daughter who has completed MCH in reproductive medicine, and Dr. Namita, congratulations to you. So, sir is the professor in the Department of OBGY at CARES JN Medical College and senior consultant KLES, Dr. PK Hospital, Belagavi. Sir has been the president of KASOGA in the years 2018 to 19, Secretary General of KASOGA 12 to 13. Sir holds a fellowship in perinatology from USA, Global Network, a division of NICHD USA scholar, principal investigator for international trials dealing with labor, CLIP, preterm labor, cradle trial, and Rapidiron, fellow of ICOG with 75 more than 75 publications in high impact factor journals, several book chapters, books, and more than 1,000 guest lectures at regional and international academic events. Google Age Index of 17 and Scopus Age Index of 13. These are the academic activities to his credit. Expert review member of ICMR for Center of Excellence on Preeclampsia. Awardee of Teacher of Teachers Award in 22, Best Scientist Award 2013-14, Best Teacher Award 2010-11 from Career Team to be University. MS Signature International Award for Phenomenal Leadership and Excellent Academician Award 2020, Newton Baba Award from MRC London and DBT for Cradle Trial Team 2017, Chief Guest and Speaker at the Residence Induction Program at St. Thomas Hospital, London, UK 2017. We are honored to have you amongst us, Dr. Bellard, sir, and we would love to have blessings from you, sir.
Good evening, everyone. I think, madam, you are too elaborate and don't waste on these. I request you to be more concentrate on the academic because the audience will get bored of us and they have seen us. And I just really humbly thank you for that. But for all the speakers, everyone requests the same because we are all known to each other. And I must congratulate you and your better half. Who is also a very, very humorous person with us. That day we all enjoyed on that day. And it is a hearty congratulations on choosing this wonderful topic of, the endometrium decoded. However, we have depth of information on endometrium. It still, I feel that it's really an enigma to understand the endometrium. All of us know. So, but your webinar is going to highlight the importance of this endometrium in all areas, be it for the infertility, be it for the conception, interception, or even relevant to how it grows in a different situations, how it matters in PCOS, how it matters for the oncology. So it's really a wonderful organ, and when it is out of its area, how it also manifests is a very, very wonderful thing to learn. So I think we are learning from this webinar very detailed information about this endometrium. Madam, you have rightly chosen a topic, and all the special guest speakers, guests, chief guests of honor, and all the speakers, I must congratulate them for being part of this. And special thanks to you both, Ranbir Singh and you, Monica, madam. Thank you for involving me as a special guest. I immensely thank, and all the best for this webinar. Thank you.
Thank you,
Thank
Mr.
you.
Sir. Thank you.
Thank you so much, sir.
Thank you.
And thank you, sir. And now I invite our special guest, Dr. Rajendra Nagarpati. Dr. Rajendra Nagarpati is Honorary Treasurer of Mumbai Obstetrics Society, and he has been the past chairperson of the past chairperson of EMOX Midlife Management Committee, founder secretary of Mumbai Chapter ISOPOP, president of Obstetric and Gynecological Society of Meera Bhayandar, past president and advisory board member of AFG Mumbai, elect the Association of Medical Consultants AMC Mumbai, past president and trustee of
Thank you,
IMA
madam. Thank you.
Bhayandar branch, past president. Sir, we welcome you. I know your achievements are very many, and we just want your words on this program, sir.
Thank you so much. Yeah, so as Dr. Ballard said, it's a real honor and pleasure to be on this Synergy webinar, and we thank you, Dr. Monica and Dr. Ranjit Singh, for inviting us and making us a part of this. I wish to extend my regards to Dr. Sarita Balerao and the other guests of honor, Dr. Neeraj Jadhav, a very dear friend, and also Dr. Ballard sir, who's such a great academician. So it's a real pleasure to share the platform. I wish to congratulate you for setting a very wonderful program with great speakers, Dr. Sheshadri, Madam, and Dr. Bhagya Lakshmi. And as my previous special guest mentioned, the endometrium is such an important organ for women. It has a role to play at every level, right from adolescence to reproductive age. Today, our IVF specialists are, breaking their brains over thin endometrium and trying to do everything possible. And then in the post perimenopausal area, they are trying to, bring down the endometrium and prevent endometrial cancers and things like that. So at every different point, it has a role to play, and truly it's an enigma. And so therefore, this webinar is going to be very, very interesting. So congratulations, and congratulations to both of you for your election, victory in the ISAR elections, both in the clinician and in the embryology side. And we wish you the very best in your endeavor for the FOXY chairperson of Infertility Committee. So we wish you the best, and you're going to really win it hands down. So best wishes to you. And without further ado, I think I will hand it over back to you with one request. I am standing for the post of Vice President FOXY West Zone. So I request support from everyone in this regard. So thank you so much. And once again, thank you, sir. And with this, I will hand it over back to you, Dr. Monica. Thank you.
Monica, one word about Supriya Sheshadri. Shall I say?
Yes, sir.
Yes,
Yes,
sir. Sure, sir. Sure.
Supriya Sheshadri is an amazing ultrasonologist. I invited her to my place. She caught the whole audience into her this, and she is a great sonologist and amazing person, and very unassuming personality she has got. I tell you, she will make this webinar worthwhile. And Monica and Ranbir Singh, hearty congratulations on getting elected as ISAR members. Also, all the best for your committee chairpersons, and we will support you. Thank you so much.
Thank you. Thank you,
Thank you,
Bernard, sir.
Mrityunjay sir, and best wishes, Rajendra sir, for your election for VP. We are all from heart supporting you, sir.
Thank you, sir. Thank you. Thank you. Thank you.
There are so many Foxy people and so many mentors on this platform. We all wish you the very, very best for your election. We want to see you as Vice President West Zone, Foxy.
Thank you
So
so much.
thank you, sir, for being there. And now I would like to introduce our societies who have given us their kind presence and their, their support to us for this program. I would be lacking in my duties if I don't thank my better half and co-convener, Dr. Randhir. We know his contribution in ISAR. Myself, your host. And now I would like to thank our societies. We first start with Firozabad OBGY societies. The societies are in alphabetical order, so there is no hierarchy here. Firozabad OBGY Society, headed by Dr. Prerna Agarwal and Dr. Priyanka Agarwal as secretary, is one of the dynamic societies of the state of Uttar Pradesh. Dr. Prerna Agarwal is heading the MC Agarwal Hospital and Dr. Prerna IVF Center. She is heading the Firozabad OBGY Society and has been practicing a clean sonologist for more than 35 years, dealing with infertility, high-risk pregnancy, faculty in various conferences, and also the founder secretary of Firozabad OBGY Society. Welcome, madam. Prerna ma'am is there. Next, I would like to invite the Secretary Firozabad OBGY Society, Dr. Priyanka Upmanyu Agarwal, who has got connections from Bhopal. I came to know when I talked to her. She is a gold medalist, a CBSE 12th board topper. We can understand the value of that, topping 12th board. She's also been awarded for her poster presentation on HELP syndrome. So she's a keen obstetrician in the 9th MPOX, which was held in Riva. Achievers Award for 2023 in North Zone Yuva Foxy, as well as a very good speaker, panelist, and coordinator. We welcome you, Priyanka. Are you there? Next, I
He
would like
will
to
not be
pay
able to join.
Yeah, I think they are busy. Both of them did extend their apologies. So now I would like to acknowledge the Ghaziabad OBGY Societies, which has collaborated with Synergy under the presidentship of Dr. Alpana Agarwal and Dr. Chaya Goyal as secretary. Dr. Alpana Agarwal is the Dean Medical Superintendent of Santosh Medical College, a very renowned medical college and hospital in Ghaziabad, with awards like Academic Excellence Award by Santosh University, Best Scientific Activity Award by IMA Ghaziabad, and the Corona Warrior Award by IMA Ghaziabad. She is a teacher of teachers with a teaching experience of more than 26 years and a keen academician. We welcome you, Alpana ma'am. Next, we would like to acknowledge the Secretary of Ghaziabad Society, Dr. Chaya Goyal, who is a senior consultant at Hiralal Hospital, Ghaziabad, and a secretary of the Ghaziabad Society with special interest in high-risk pregnancy. We welcome you, Dr. Chaya. Next, I would like to acknowledge Gorakhpur OBGY Societies under President Dr. Dipti Chaturvedi and Secretary Dr. Upma Yadav Jaiswal. Dr. Dipti Chaturvedi is also responsible for bringing together the gynec and the oncology fraternity of Gorakhpur together. She is very active in ISOPAP, IMA, as well as the Obstetric and Gynec Society of Gorakhpur, and has received several awards of appreciation for exemplary contribution to IMA as well as Foxy. We welcome you, Dipti, madam. Next, I would like to welcome the Secretary of Gorakhpur OBGY Society, Dr. Upma Jaiswal, who is the Director of Swastik Marigold Multi-Speciality Hospital and heading the Gorakhpur OBGYN Society as Secretary. She is a teaching faculty in ABCDI, Pune. Welcome you, Upma, madam. Next, I would like to acknowledge Jaunpur OBGY Society under President Dr. Shubha Singh and Dr. Shelly Nigam as Secretary. Dr. Shelly, I just saw here in the audience. Dr. Shubha Singh is an alumnus of the renowned GSVM Medical College, Kanpur, and one of the founder members of Jaunpur OBGY Societies, which was established in 2002, and the director of Harshit Medical Center Private Limited, Navjeevan Hospitals, Jaunpur. Welcome, madam. I would like to welcome Dr. Shelly Nigam. Shelly Nigam has also got a connect to Bhopal. She was in Bhopal Obsgynae Society a short time ago, and now she is secretary of the very vibrant Jaunpur OBGY Society. Again, a very dynamic gynecologist, recipient of Indumati Javeri Prize for Best Paper Presentation in AICOG 2008, and member of all the organizations which are of worth, as well as several publications. Of mention is she's received a prize for best publication of Jogi in 2011. Her study was on lactic dehydrogenase, a biochemical marker for preeclampsia and eclampsia. Welcome, Shelly. Are you there?
Thank you. Thank you so much, ma'am.
Would you like to speak a few words?
Ma'am, it's really an honor to join this webinar, and the topic is really very good. I am expecting a lot of good discussion and good learning in this session. Thanks for joining Jaunpur Society to this webinar.
Thank you.
And
Thank
a
you.
lot of congratulations to you and sir for your recent win in SR, and my best wishes to both of you.
Thank you so much, Dr. Shelly. Dr. Upma, madam, would you like to say a few words for us, madam?
Yes, ma'am. It is always very encouraging. You invite us for such dynamic webinars, and this hour and everyone is going to benefit from your participation as office bearers. And we are always looking forward to your seminars and as well as webinars, ma'am. And endometrium, we all know, is a very dynamic organ. And just by looking at endometrium via TVS, we can diagnose so many diseases that it has become a day-to-day tool for us in OPD. So with this discussion, we're going to definitely gain, everyone's going to gain in knowledge by this webinar. Thank you, ma'am.
Thank you, Upma, madam. Dr. Dipti Chaturvedi, madam, you have joined, ma'am. Dr. Dipti, madam, would you like to speak a few words, madam?
Yeah. Thank you. Good evening. India is very burning topic of the modern era, and endometrial cancer also. And though endometrial cancer has quite less an incidence, but endometrial hyperplasia is very common. And if left untreated, it ends up into that only. Of course, there are genetic factors, but we would like to hear elaborately, and that's why today I am here to listen to all these stalwarts. And congratulations to you and your whole team. Nice work.
Thank you. Thank you, Dipti ma'am. Dipti ma'am has been a part of our program before also. So we look forward to your participation, madam. Next, Dr. Vishal, I'll be introducing Mathura Society. Mathura Society under the office bearers, Dr. Prerna Agarwal and Dr. Nilima Agarwal, the president and secretary of Mathura OBGY Societies, which is very vibrantly celebrating the Mahashivratri. I came to know. Another dignitary from Mathura Society is my very dear friend, Dr. Vartika Kishore. Yes. So, hello, Vartika. And I welcome Dr. Prerna Agarwal, President, and Dr. Nilima Agarwal, Secretary of Mathura, along with Vartika, to be in this program. Vartika, would you like to speak a few words?
Thank you, ma'am. And it's always a pleasure being associated with you and sir. And quite a few of Synergy webinars before I have attended. And it's really a great learning experience. And you both are true academicians. And congratulations for SR victory. And one more victory of your daughter, that achievement. And hoping all the best wishes in your future endeavor. Thank you, ma'am. Thank you so much.
Thank you so much, Vartika. Thank you. Vartika is one of the most positive people I've ever met in my life. So best wishes, Vartika. Next, last but not least, my home state society, Ratlam, which is very close to my heart, headed by my very dear friends, Dr. Sunita Wadhwani, Madam, is President, and Dr. Aditi Rathore is Secretary. They are heading a very dynamic and brilliant society. Dr. Sunita Wadhwani is not only President of Society, but also running a very busy hospital, Ratlam Hospital and Research Center. She's NABH assessor. She takes out time in between her clinical work to do the NABH assessments. She's MBA in hospital and healthcare, a special interest in critical obstetrics she has, and she's also the lead assessor and master trainer in Manyata by Foxy, which is responsible for training all our paramedical staff with the best practices in hospital running. So welcome, Sunita ma'am. We would like to have a few words from you, madam.
Hello, Dr. Monica. First of all, congratulations for the victory at ISAR.
Thank you so much.
And we really look forward to your webinars. I have attended few of your webinars before this also, but your webinars are always very informative and worth the time we spend on this webinar. So we really are looking forward. And endometrium per se is not discussed that often. So it is really nice that you came up one single topic, endometrium. I have never attended a webinar which stands on this. So we are looking forward to a very good and academically filled evening. Thank you very much.
Thank you, Dr. Sunita. We know how busy you are, and still you have taken out time for the introductions. Thank you so much. Aditi is there, Dr. Aditi. Dr. Aditi Rathore is another very, very dynamic. And the one thing about Dr. Aditi which caught my interest several years back were her answers during an ultrasound panel in my webinar. So she is a very keen sonologist. Again, a certificate in hospital management she's carrying. She's a consultant at Rathore Nursing Home in Jaora, and at the same time heading the society as secretary. Welcome, Aditi. A few words from you. You are in the OT, I think.
No, ma'am. I just got free. Thank you, ma'am, for having me here. A very warm good evening to everyone present here, all the big dignitaries I can see. Thank you for having a constellation of stars, here. And congratulations on your recent win in SR, and looking forward to see you bearing other posts in future with our full support, ma'am. Thank you for making us a part of this webinar. Best wishes to you always. Thank you, ma'am.
Thank you. Thank you so much, Aditi. And the program could not have been compiled without my coordinators, who are like the four arms I have. So Dr. Manila Jain Kaushal from Indore has joined us as advisor. She suggests the scientific topics we are going to do next. Dr. Purva is one very active coordinator who is also associate professor at Gandhi Medical College, Bhopal. Dr. Ankita Upadhyay is assistant professor at Chirayu Medical College, Bhopal. And Dr. Virul Srivastav is a very dynamic fertility specialist from Bhopal. So these three ladies keep the program going and very, very actively coordinate the whole program. That is why we can get such a galaxy together. Thank you to all three of you. So now, without delay, I hand over the first session to Dr. Purva to start the first talk. And before that, my heartiest respect and regards and thanks to Dr. Supriya Seshadri Madam and Dr. Bhagilakshmi Nayak Madam and Dr. Jaya Bharti Ma'am for accepting our invite. We are thoroughly indebted to all three of you. Thank you, madams.
Thank you so much, ma'am. Yes, ma'am. Now moving towards our first academic session, differential diagnosis of thickened endometrium in USG. To chair the session, we have Dr. Chaya Goyal, madam, Dr. Upma Yadav Jaiswal, ma'am, Dr. Shalini Nigam, ma'am, Dr. Vartika Kishore, ma'am, Dr. Neelima Agrawal, ma'am. Dr. Chaya Goyal, madam, she is at present secretary of Ghaziabad OBGY Society, and she's a senior gynecologist there. We welcome you, ma'am. Next, we have Dr. Upma Yadav Jaiswal, madam. Madam is presently secretary of Gorakhpur OBGY Society and is director of Swastik Marigold Multi-Speciality Hospital, Gorakhpur. We welcome you, ma'am. Next, we have Dr. Shalini Nigam, madam. Madam is presently secretary of Jaunpur OBGY Society, and she is director and consultant of Himani Hospital, Jaunpur. We welcome you, ma'am. We have with us Dr. Vartika Kishori, ma'am. Madam is a very senior gynecologist at Mathura. We welcome you, ma'am. We have with us Dr. Neelima Agrawal, madam, director of Shri Krishna Hospital, secretary of Mathura OBGY Society. We welcome you, ma'am. Now I hand over the session to our chairperson to introduce our speaker, none other than Dr. Supriya Seshadri, madam. We welcome you, ma'am. Over to chairpersons.
Dr. Shelley. Dr. Shelley, please unmute.
Dr. Shelley, ma'am.
It's really an honor and pleasure to introduce our renowned speaker today, Dr. Supriya Seshadri, madam. She is MD in Obs-Gynae and she has done fellowship in maternal fetal medicine. She has been trained in obstetric ultrasound at Fetal Foundation of India under Dr. B.S. Ramamurthy 2004. She is consultant sonologist and she has been working in various centers. She has been scientific coordinator and faculty for Opus simulator based gynae in fertility and fetal ultrasound since 2000 till date. She is a faculty for gynae ultrasound, Marrow Obs Gynae residency and clinical imaging program. Has been contributor to content of ICUOG online education advanced training curriculum 2021, expert trainer for simulator based gynae ultrasound 2018 till date at Garb Gudi Infertility Center. She is editor of e-newsletter Fetolog. I welcome you, ma'am, and I request you to start your talk.
Okay, good evening all, and thank you. Let me first share my screen. Can you see my slides?
Yes, ma'am.
Yes,
Okay,
ma'am.
again, thank you for having me over, and it is an honor to be here among so many very well-renowned people. Thank you, Dr. Balat, for the kind words you've said. I hope I can live up to your reputation. And also all the office bearers of the various societies, thank you for being here. So I will go on to my topic, and that is thickened endometrium, the differentials, and ultrasound. Basically, this talk at my practice revolves around what we call AITA, which all of you are familiar. Now, AITA introduced first in 2010, where they brought in the terms, definitions, and measurements. Then they went on to very niche categories such as abnormal uterine bleeding, no abnormal uterine bleeding, postmenopausal bleeding. And very, very recently, that is in Jan 2026, they've also come up with a consensus statement. Now, the point is, like, if we know these articles, then we can definitely do a very good job in ultrasound scanning of the endometrium specifically, because all that they describe is very simple and easy to follow, and all that's required is just 2D ultrasound. Now, coming to the topic, thickened endometrium, first and foremost, it's an objective and not a subjective finding. Now, how do we measure the endometrium? We take the view the endometrium in what is called the sagittal plane of the uterus. We get the endometrium as far as possible perpendicular to the ultrasound beam, magnify the image, measure the thickest proportion of the endometrium, that is outer basal to outer basal, meaning the endomyometrial interface, do not include this halo around the endometrium. And the measurement is always taken in terms of millimeters. The same principles apply when we're doing a transabdominal measurement of the endometrium as well. Now, these two images, again, to show the thickest part of the endometrium is measured. And I mean, I don't know about dedicated practices, but certainly AITA does not say that measure the endometrium 1 to 1.5 centimeters from the top, below the top of the uterine cavity. Now, what is incorrect in all these images is this is incorrect because this is not a magnified image, and therefore these borders may not be seen so clearly. Remember, even a few millimeter makes a lot of difference. Now, this certainly is incorrect because endometrium sagittal plane should appear like a leaf. But when the endometrium appears like a triangle, then we are certain that because of the position of the uterus, the ultrasound beam has insulated the uterus to give us coronal planes. And even without me telling you, you will know that when we take a measurement in this kind of endometrium, it is certainly going to be very large. So my first message here is, before you report a thickened endometrium or you see a report with thickened endometrium, always look at the image. In the image, if the endometrium appears triangular, then you know that it is not the correct plane. Now, I have seen some people measure the endometrium transversely. This is totally incorrect. And I think where they are coming from is against the background of uterine anomalies, wherein we need to measure the endometrium in two horns, and getting a sagittal plane of both the horns can be tricky. It's not at all difficult, but can be tricky. But even then, there is no excuse or reason to take the endometrial measurement in a transverse plane of the uterus. When it comes to pathology, again, there are certain rules. If there is fluid inside the cavity, then AITA recommends taking what is called the single layer thickness. So we take a measurement this side, anterior to the fluid, take a measurement posterior to the fluid, and add up the two to give us the endometrial thickness. If there is a polyp, now very soon I will tell you how we differentiate a polyp. If there is a polyp, then you go across the polyp as the endometrial thickness, because polyp anyway is endometrial in origin. On the other hand, if there's a fibroid polyp, we do not go across the polyp because fibroid polyp is not endometrial origin. Select the maximum, widest area of the endometrium other than the polyp, fibroid polyp. And if you see something like this, wherein we cannot see the borders, we cannot see the interface between the endometrium and the myometrium, then AITA says, please write non-measurable and do not attempt to measure the endometrium in such cases. Now, how thick is thick? In the premenopausal, there is no consensus on the endometrial thickness cutoff. And the consensus statement, I have actually copied it verbatim, says that endometrial thickness changes continuously in response to hormonal stimulation. Unlike after menopause, a cutoff value for endometrial thickness is not useful prior to menopause, and endometrial features other than thickness are more relevant. However, for those of us who are fond of numbers and seeking numbers, then this is a number that we could go with. In the premenopausal lady with abnormal uterine bleeding, the cutoff is equal or more than 12 millimeter. Without abnormal uterine bleeding, in the proliferative phase, the number is 14 millimeter. In the secretory phase, it's 16 millimeter. Easy to remember. Premenopausal, 12, 14, 16. How about postmenopausal with bleeding? Again, there is no one cutoff. Now, this study examined the endometrial thickness ranging right from 3 to 15 millimeter. And what they concluded was 3, 4, and 5 gave the best sensitivity and specificity. And practically most practitioners use a cutoff of equal or more than 4 millimeter to call it abnormal in a postmenopausal lady with uterine bleeding. However, lower the cutoff, lower the rate of false positives, and hence some even take 3 millimeter as their criteria. What about the postmenopausal lady without bleeding? There is no consensus on the ET cutoff. Some authors give us more than 8 millimeter, some more than 10 millimeter, and some others more than 11 millimeter. Again, this study, which looked at the thickness ranging from 7 to 12 millimeter, found that the best sensitivity and specificity was 8 millimeter, but 11 millimeter had the highest specificity, and therefore some use 8 and some use 11. And this review, although it's pretty old, I think will still hold good, wherein they concluded that endometrial thickness measurement has no value in a postmenopausal woman without bleeding. So what do we do? We should not stop at thickened endometrium, always look beyond the thickness on ultrasound. That is, we look for causes. And these are the various causes of a thick endometrium, starting from the most sinister, that is endometrial carcinoma, endometrial hyperplasia, endometrial polyp, a submucous fibroid, endometritis, and anovulatory. Now, this table will easily tell us that there's a huge overlap in thickness between the different pathologies, and therefore the dictum look beyond thickness, and by this we mean look at the endometrial morphology in a qualitative way. So what do we look at? We look at endometrial echogenicity, endometrial midline, endomyometrial junction, endometrial vascularity, and this we report in terms of color score as well as vessel pattern. And this is again from the AITA group. So looking at echogenicity, there are two categories, uniform, non-uniform. Uniform is also called homogeneous. Now this is described as a hypoechogenic endometrium. This is an isoechogenic endometrium, and this is a hyperechogenic endometrium. In order to apply the terms hypo, iso, hyper, we compare the echogenicity of the endometrium to that of the myometrium, and therefore put in these words as such. Also, the endometrium needs to be symmetrical with the anterior and posterior walls of the uterus as well. The non-uniform category will be a heterogeneous endometrium, will be a cystic endometrium. This means there are anechoic spaces within the endometrium. The anechoic spaces can be single, multiple, can be small, can be large, can be regular, can be irregular. Whatever it is, it makes it the category of cystic endometrium. And the other category of non-uniform endometrium is what we call asymmetric endometrium, wherein the endometrial contour is not uniform. Next, we look at the endometrial midline. Normally, the midline is straight, like uninterrupted, what is called linear. It is hyperequic. Now, easy to understand why it is hyperequic. One of the dictum ultrasound is anywhere in the body wherein two mucosal surfaces meet, they cast a hyperequic line. An abnormal midline will be an interrupted midline as seen in RPOC, as seen in a fibroid polyp, as well as seen in an endometrial polyp. Next, we look at the endomyometrial junction. This is comprised of the basal endometrium and the hypoequic halo around, which is the junctional zone. The junctional zone is actually the inner myometrium. This EMJ can be well seen on 2D, but brought out better on 3D. Now, what is not normal is what is called an irregular EMJ, seen on 2D as well as in 3D, and an interrupted EMJ, again seen on 2D as well as 3D. Vascularity is extremely important, and what this goes after the IOTA terminology of vascularity, and it is extremely simple. So here the message is there is no role for PI and RI. Routinely, when we study vascularity of the endometrium, either a normal endometrium or an abnormal endometrium. Now, color score, we go by what we term as color score. So when there is no color, it is termed color score 1. Remember, there is nothing like color score 0. When there is minimal color, it is color score 2. When there is moderate color, it is color score 3. And when there is abundant color, that is color score 4. However, in order to get the right color score, there are certain principles that need to be followed. The first is when we do Doppler in gynecology, do not use color Doppler. Instead, use the power Doppler, because power Doppler actually maps the strength of the signal coming from the blood vessel. Adjust the color gain, and also if we do not see color, bring down the PRF to 0.3 to 0.6. So only after we have followed these principles can we assign a color score. Now coming to each pathology, in an anovulatory endometrium, which is a very common cause of a thick endometrium, the thickness can vary anywhere from 6 to 13 millimeter. This is what we call a homogeneous hyperechoic endometrium. Now you'll be familiar as to why we call it homogeneous and hyperechoic. The midline is linear. The EMJ is regular. Color score 1 means in 50% of cases, there is no color. In the other 50%, you might get some color. But even when we get some color, the vessel pattern is non-specific. The most common reason for a thickened endometrium or abnormal uterine bleeding is an endometrial polyp. And a polyp is a localized overgrowth of endometrial tissue, which is secondary to either increased estrogen or chronic inflammation. It's composed of glands, stroma, and blood vessels, and which are covered by the epithelium. The epithelium can be secretory, proliferative, or hyperplastic with or without ATPR. In symptomatic women, the prevalence of polyp, especially in those with abnormal uterine bleeding, is as high as 40%. If we also see it in asymptomatic women to the rate of 12%, it's more common postmenopausal, but I would not go with these figures because we do see a lot of polyps even in the premenopausal age group. One thing to remember is the symptoms do not correlate with the polyp number, size and site unless we are dealing with infertility. How do we recognize an endometrial polyp on ultrasound? The thickness, again, doesn't matter at all. It can vary anywhere from 8 to 14 millimeter. This is described as a homogeneous hyperechoic or can be heterogeneous. There will be cysts. The cysts are more common in the postmenopausal as compared to the premenopausal. The clue here is the midline is split, the EMJ is regular, and color score 2 or 3, which means mild, minimal, or moderate. Now, the vessel pattern here is a single vessel, which may or may not branch, but even if it branches, it's never more than 4 or 5 branches. Now, this vessel is termed as a thick dominant vessel or a feeder vessel or the pedicle artery sign. It is important that we pay attention to when we will actually pick up endometrial polyps best. I've heard quite a few people say post-menstrual, not really. the best time to pick up an endometrial polyp is between day 10 to day 12. Now, these are images of a lady, 28-year-old, history of endometrial spotting since 3 months. This is the appearance of the endometrium day 22 of cycle. I know the Doppler would have given me more information, but let's admit it, sometimes our Doppler settings are not very good in the machines, and therefore we can't really take recourse to Doppler. So what do we do in this case, or at least what I do, certainly I will write in the report, rescan day 10 to day 12. Now, why do I choose day 10 to day 12 is, in that period, the endometrial echogenicity is hypoechoic. The polyp, because it's mucosal, is hyperechoic, and therefore there's a good contrast, and therefore the polyp stands out very well, as you can see in these images. A definite clue to the presence of polyp is what we call the bright edge sign or the white line sign. Now, as I've just stated, whenever two mucosal surfaces meet, they cast a white line. The endometrial leaf is also mucosal, the polyp is also mucosal, and that's why we get this line, and this is a huge clue, this is the best clue to pick up a polyp. Endometrial polyp can be benign or malignant. They may be single or multiple. They may be small or large. They may be sessile or pedunculated. Around 20% of them, 27% of them regress at the end of 1 year. And therefore, if the lady has no symptoms, it's advisable just to observe, or if the polyp size is less than 10 millimeter, expectant management. And however, one must note that if the size is more than 15 millimeter, then regression is less likely. When we suspect hyperplasia or malignancy in a polyp, when the polyp has an irregular outline, when the size is more than 18 millimeter, there are multiple branching vessels, and here I would use RI, and if the RI is less than 0.5, then suspect malignancy. This study, in fact, concluded that polyp size, patient's BMI, and intralesional cystic spaces were the best discriminators between benign and pre-malignant or malignant polyps. In that series, they found no cases of pre-malignant or malignant changes in polyps when the BMI was less than 28, polyps measuring less or equal to 13 millimeter in mean diameter, and cystic spaces within the polyp. One must note that the risk of malignancy in a polyp increases only after 50 years of age, and if more than 60, the risk of malignancy is almost 2 or 3 times more. Coming to the other differential, the submucous fibroid polyp, here again, thickness has absolutely no bearing. The endometrial echogenicity by AITA is described as homogeneous hyperechoic, and I'm thinking that they're referring to the endometrium and not to the fibroid polyp, because always a fibroid will be hypoechoic. Now, heterogeneous kind of fits into the description. Here again, the midline may or may not be defined. The EMJ is interrupted, and it has always minimal or moderate color score. But what is the clue? The clue is the peripheral vascularity. One must know that when we're looking or when we are reporting peripheral vascularity, it's not important that we get a 360 vascularity. The vascularity in the periphery may be just focal or segmental, in which case we still say there is circular flow, and that goes in favor of submucous fibroid polyp being the cause of the abnormal uterine bleeding. Endometrial hyperplasia, again, not uncommon at all. Now, what is it? It's a precancerous, non-physiological, non-invasive proliferation of the endometrium, but it is a histological diagnosis. The cause is it results from increased estrogen effect on the endometrium. WHO puts the hyperplasia into 2 categories, one without atypia and one with atypia. It can coexist in 40% of cases with endometrial carcinoma. It may most often presents with abnormal uterine bleeding, usually seen in the perimenopausal women. 5% occur at less than 40 years of age. It may be seen in asymptomatic women as well. A clue is on Pap smear, when we get abnormal endometrial glandular or stromal cells, we must look for the presence of endometrial hyperplasia. Now, how does it appear on ultrasound? Various patterns on 2D. This is cystic. This is uniform, hyperechogenic, and this is described as heterogeneous. But the giveaway for a hyperplasia is in the vascularity. Now, vascularity is described as a multiple vessel, multifocal origin. So what do we see? We see parallel vessels crossing the AMJ and entering the endometrium. Here, the midline is not seen. The color score, in fact, I mean, I can't really vouch for this, but AITA says that you may not get vascularity at all in endometrial hyperplasia. So if there's a color score of 1 or 2, it goes in more in favor of no atypia. But if there is 2 or 3, then suspect atypia. But as I repeat again, it's multiple vessels, multifocal origin. Now, the other pattern, yes, we do see sometimes, is a scattered vascularity. The difference here is in scattered vascularity, these vessels do not cross the AMJ to enter the endometrium. The other presentation of a hyperplasia is what is called a polypoid endometrium. Now, I know quite a few will agree with me that this appearance is reported as multiple polyps. The main difference of why we do not call it a polyp is here the endometrial midline is continuous. And why is it? This is called a polypoid endometrium. And why does it result? Because of the excess estrogen, the endometrium multiplies so much that it forms folds, but they are all in the basal layer. When there is endometrial hyperplasia, always look for the source of estrogen, because unless the cause is attended to, DNCs are not going to help. So what is the cause? It could be a polycystic ovary, or it could even be a functional cyst in the ovary. Endometrial carcinoma is another category for thickened endometrium. It is the term applied to a malignancy arising in the endometrium. Predominantly, it is a disease of the postmenopausal age group. However, 5% is seen in less than 40 years of age, and it is usually diagnosed early because of the symptoms and therefore has a good prognosis. The incidence of endometrial carcinoma, and I'm sure you hear a lot more about this, but what the figures I got is 4.3 per 100,000 women in India. And more than 90% of women with endometrial carcinoma present with postmenstrual bleeding, but we should remember that over 90% of women with postmenopausal bleeding have a benign underlying cause for their symptoms. What is this presentation on ultrasound? Quite a thickened endometrium, a heterogeneous appearance with or without cysts, or there may be an irregular focal lesion. The midline is not defined. The EMJ is interrupted in more than 50% or close to 50% of cases, but the giveaway is in the color score. There is abundant color, and the vessel pattern is described as a multiple vessels of a focal origin or a multiple vessels of multifocal origin. Now, this study, in fact, very easily depicted the Doppler pattern. This is what they call irregular branching, multiple densely packed vessels, or color splashes. Now, whenever we see this kind of pattern in a thickened endometrium, always think of endometrial carcinoma. There is an easy scoring system in order to know the risk for endometrial carcinoma. Herein, the lady's BMI is taken into consideration, more or equal to 30. Each of this is given a point of 1. The second is an endometrial thickness of more than 10 millimeter, an endometrial thickness of more than 15 millimeter. There is vascularity, but it is not a single dominant vessel. There may be multiple vessels, there may be large vessels, densely packed vessels, an interrupted EMJ or an irregular EMJ. Now, a mark of 1 is assigned to any of the features present, and if there's a score of 3, the detection rate for endometrial cancer is as high as 90%. However, we should remember that type 2 endometrial carcinomas, such as uterine papillary serous carcinoma, yes, clear cell carcinoma, and other high-grade endometrial carcinomas are more likely to be found in women with a thin endometrium. Then what is the difference on ultrasound between hyperplasia and endometrial carcinoma? One is the thickness. Second is hyperplasia is one of the pattern is homogeneous hyperequipped, which you'll never see in a carcinoma. An interrupted EMJ is seen in a carcinoma, not in a hyperplasia. Abundant or moderate color goes in favor of a carcinoma. A scattered pattern goes in favor of hyperplasia, and multiple vessels of focal origin goes in favor of carcinoma. The last category of a thickened endometrium could be endometritis. However, endometritis can even present with a thin endometrium. What is this appearance? It describes heterogeneous. Yes. The midline is undefined. Yes, please.
So, ma'am, आगे पीछे साइड दोनों जगह 4 by 6 4 by 6
mute everybody. Support team, please mute everybody.
To
Very
mute
ठीक है इसको हम आपको भेज देते हैं वहां पे
Support team,
इसको
please mute everybody.
अभी तो कंप्लीट भी नहीं है अभी आगे वाला तो
Support
मुझे
team,
टाइम
please
नहीं
mute
पता
everybody.
Instructions.
कितना बचे?
It breaks the monotony of
ये इसी की
listening.
बात
That's
लिख ही नहीं
fine.
पाए कहाँ गया
Dr. Abha, madam, could you please mute yourself?
फाउंडेशन डे
That's okay. It breaks the monotony of the lecture.
तो
That's
बचे हुए
fine.
हैं ये सारी एक्टिविटीज
Sorry. Very sorry, madam. Very
No,
sorry.
no, that's fine. As I said, it breaks the monotony, so it's good. Now, EMJ can be described as irregular, hazy. We really don't see an EMJ. Now, the vessel pattern is non-specific. We can get endometritis with no vascularity at all, or you can get abundant vascularity. So, in summary, a report should not stop at thickened endometrium noted or the very famous line to be clinically correlated. The thickness should also always be taken at the widest anterior-posterior diameter in the sagittal plane of the endometrium. There is no one universal cutoff, be it premenopausal or postmenopausal. However, the cutoff that works in a premenopausal lady with abnormal uterine bleeding, as I said, 12, 14, 16. In postmenopausal with abnormal uterine bleeding, 3, 4, 5. And without abnormal uterine bleeding, 8, 10, and 11. Look at the whole picture. That is thickness along with morphology and vascularity of the endometrium. Now, these are different images. This we know is a homogeneous endometrium, cystic endometrium, heterogeneous endometrium, and this is also heterogeneous, and this is also heterogeneous. However, Doppler helps differentiate. So when we use power Doppler with a PRF of 0.3 to 0.6, an ovulatory will most often not have any color inside. A cystic, which goes in favor of endometrial hyperplasia, will have multifocal, multiple vessel origin. An endometrial polyp will have a single dominant thick vessel. A submucous fibroid will have peripheral vascularity, and a carcinoma will have a disorderly arrangement of the vessels. However, the final word is in women with abnormal uterine bleeding and at high risk of malignancy with a hyperplasia or carcinoma, consider endometrial biopsy regardless of thickness and morphology. And the risk factors to be borne in mind is age more than 40 years, obesity, nulliparity, family history of gynecologic malignancy, polycystic ovarian syndrome, type 2 diabetes, chronic hypertension, and atypical glandular cells and pap smear. Then one might ask them, why at all do I scan? Then it is always good, like when we're walking on a footpath, though we know that there are no vehicles, no trees, no pets, still we walk with our eyes open, isn't it? We don't walk blindfolded. Same way, when we do a DNC or biopsy, it's better to know what to expect rather than go in not knowing what to expect. Now, I'd like to end this saying that any of you interested in simulator-based hands-on training 2D, please contact me. I've been in this field since 2018 on 2 different kinds of simulator. And as we all know, ultrasound is real time. So when you do it on hands-on, you will get a much better grasp of the subject rather than listening to lectures. Now, thank you very much for a patient hearing.
Thank you. Thank you so much, ma'am. Any comments from chairpersons?
Yes. Thank you, ma'am. It was indeed a very insightful talk, and we have really gained tremendous with this lecture. And I really appreciated, ma'am. I think I listened. I've listened to you before also, but today was a very enlightening experience. Thank you, ma'am, so much.
Thank you.
Ma'am, I would like to say that you really very well covered the minute details of endometrium, and that was very important that look beyond the thickness. So we have to look for all the details. You explained very well. But I have a question I would like to put up.
Yes.
Sometimes some RPOC retained products also we get confused with endometritis, like the endometrium is heterogeneous, there is vascularity. So what is your comment about that? How should we differentiate or
See, there are two things here. One is RPOC is always against the background of pregnancy. Endometritis, no background. No, the other thing, are you referring to an infected RPOC? No, RPOC, okay.
sometimes old RPOCs they also get infected also.
Okay, if
But
you talk,
we get heteroechoic collection, which is homogeneous to endometrium, but we really get confused that if it is endometritis or RPOC retained products. So
No, see,
they also present.
vascular RPOC needs to be, and especially we're talking about a chronic RPOC, vascular RPOC always needs to be attended. So there, whether you're calling it endometritis in an RPOC doesn't matter, but the fact that this lady has, finished the process of expulsion quite a few weeks back because you're saying it's chronic and there is still an RPOC mass which is showing vascularity, that needs to be attended. If you're talking about endometritis, I would think that in an RPOC only, the EMJ will be regular, except in one instance, which I kind of insist that should be in every report of RPOC, and that is the presence of enhanced myometrial vascularity. So this is a condition wherein there is subinvolution of the future placental vessels. So when we're doing the sweep at one area, you will find that there is no EMJ, no junction seen. And you will see these tortuous vessels, or like they call it serpentinous, snake-like. It may be anechoic or hypoechoic, extending from the endometrium to the myometrium. And when we put on color, we get aliasing. Now, what is the meaning of aliasing? That is, you don't get pure blue or pure red. You get a mixture of colors. And when you put the pulse wave Doppler, most often you get high velocity flow, that is 20 and more. Now, in an endometritis, you will never get this isolated pathology. In an RPOC without EMV, the EMJ will be regular, whereas in an endometritis, the EMJ is not defined.
Okay. Thank you, ma'am.
Yeah.
Millard sir? Yes, sir.
Supriya, excellent presentation and very
Thank you.
crisp.
Thank you.
I recently had just about 15 days back, I have done the DNC. This woman delivered in last week of October. She came to me, referred from another gynecologist. Her endometrial thickness was 36 millimeters.
Okay.
Postpartum, first cycle she had in January, but now she came with 36 millimeters, 3.6 centimeters.
Okay.
I initially thought it could be first some polyp or something like that it was, but when I did the scan myself, it was clear endometrium. So I was strongly suspecting, and though the vascularity, as you found that it was not classical of that multifocal origin which we see in the cystic type of endometrium, but it was not even looking like a malignant endometrium. Have you seen such type of thing, and what do you suspect? Because I'm awaiting the HPR now. Maybe in another 2 days I get HPR.
See, always if it's postpartum, the first thing I would request is some retained placenta.
No, I too thought like that, but the first is RPOC only we think, but
Yes.
it is almost October end or November first week she had delivered, and
It is
she came with a thick endometrium. But when I did DNC, it was classically coming like an endometrial tissue rather than a retained products of consumption. Anyway, I will update on this. But what are your conditions? You might think. I just wanted.
no, I always postpartum, I would always think some placental bit left behind. That placental bit has got organized, or the placental bit has undergone infection, and that's why you're getting these endometrial-like tissue. If there is vascular, I would think that only this vascularity should one interfere. Because if it's avascular, then it's bound to come off on its own, or you can give your, contract, whatever, to contract the uterus and get it out. Now, now that you mention it, even about last week, I saw a lady who was, I think 6 weeks, she had a process of expulsion. This is again 3 months ago, and she's continued to have RPOC, continued to have EMV, and absolutely asymptomatic.
Okay. Yeah.
So it can also, what do I say, go beyond the book descriptions. But I think as the final word is, if there is symptoms, we have to interfere. If there's no symptoms, leave alone.
Thank you.
Ma'am, also, ma'am, very recently we started seeing so many cases of uterine AVM following some sort of procedure or DNC or something, some abortion, something. Uterine AVM has really increased, and it's really very disheartening. Sometimes we are so tempted to do DNC, but since we always do a TVS at our center, we know what would be the consequences of blind DNC. So it's already advisable to at least get an ultrasound done before any
Okay,
bleeding.
this is one of my favorite topics. How much time do I
Yes, sir.
have? I'm willing to take it at the end, or do I have time
Yes,
now?
Supriya, your own slide, one of them had this, the endometrium. At the peripheral areas, there were black areas. They are suggestive of vessels. I think that could be even, I don't know the AV malformation of this nature, but we are getting of late AV malformations.
Okay,
AV so much increased.
No, you must give me time to answer.
Madam, you have time, ma'am. Please take your time.
Okay, there is no increased incidence of AV malformation, number one. There is increased reporting of AVM with due respects to a lot of people. Now, why we do not report now AVM, as you said, you're seeing post-procedure. Most commonly seen after a pregnancy, whether it is first trimester, second trimester, third trimester. This is what is called enhanced myometrial vascularity. This term was brought in order to take away the term AVM because, again, repeat, it is not a malformation. If it's a malformation, it's congenital. The lady should have had some abnormal uterine bleeding earlier, and the onset would have been earlier, and the diagnosis is only by those vascular studies. Now, enhanced myometrial vascularity is the term, again, given to sub-involution of vessels after pregnancy, and on ultrasound, only when we do a sweep. Remember that if you just do an ultrasound straight in, measure the endometrium, come out, you'll miss EMV. And it's only when you do a diligent sweep, you see at one point, there's a break in the endomyometrial junction, and we see these vessels going from the endometrium to the myometrium, and this is enhanced myometrial vascularity. As I said earlier, every RPOC report, you should write or expect that EMV present, EMV not present. Now, if EMV is present, what is the management? Earlier on, the management went by the velocity of the blood in that EMV vascularity, but more recent articles say the ideal management will be an ultrasounded guided suction evacuation. I would say that where facilities for ultrasounded guided evacuation is not available, then do not cure it, do not scratch. Because I'm sure a lot of us have gone through scenarios wherein we just thought it was an RPOC, took her for evacuation, and there was torrential bleeding. Now, why we should not use the term malformation? Because it's obsolete, not to be used. And if we use the term AVM, we know that the next stage should be sent for embolization, and embolization is not the management. So it's not that there's an increased incidence, there's an increased reporting for EMV mistaken as an AVM. I hope I have answered queries.
So, ma'am, if we take the vascular velocity of flow in a vessel which is crossing from endometrium to myometrium in EMV, that will show a high velocity flow vis-a-vis a feeder vessel of a polyp?
Yes, yes.
So, ma'am, what is the flow in a feeder vessel of a polyp?
Flow in a feeder vessel is pure colors, pure red or pure blue, depending on the direction of flow in the blood vessel.
It is a single feeder vessel.
Whereas vascularity in enhanced myometrial vascular in EMV is alazing. That means you don't get pure colors. You get a mixture of red and blue. And see that now alazing. I mean, again, I think it's important. Whenever we see alazing on Doppler, especially in gynae, straight our eyes should go to PRF. Now, you know there's a PRF on the menu. It's either top right or top left. If we see alazing and a PRF is 0.3 to 0.4, because alazing is only seen in high velocity flows. If it's PRF 0.3 to 0.4, that means it's low velocity. So there's a mismatch. That's a technical error. So what do we do in that case? When I see alazing, the PRF is 0.2 to 0.5, I will increase the PRF. And as I'm increasing the PRF, the colors turn to pure red or pure blue. Even if you use power Doppler, we're going to get red and blue as the colors. On the other hand, if I see alazing, my PRF is high, 0.9, 1, 1.2, then I know it's true high velocity. And this high velocity flow is only seen in EMV. So Doppler will have pure colors. A Doppler will have pure colors at a lower velocity, 0.3 to 0.4. It will not have alazing.
Yeah, and then that was the next question I had, that in many cases, when we reduce the PRF to below 0.5, we do start getting aliasing. So usually I just stop at 0.5 or 0.4. Below that, if I go, I get confused with the number of vessels. So my 0.3, how do we use 0.3 PRF effectively in our
See,
scans?
the one is now, okay, Doppler, when we use Doppler, I'm sure all of us have presets. If you don't have presets, it's worthwhile calling the app specialist and making the presets. So the presets have a designated PRF for gynae studies. Whether I use color Doppler, I will not use color Doppler in gynae, I'll use power Doppler. When I use power Doppler and I see color, I will not touch the PRF unless I see a lasing. And then I will increase the PRF. If I already see color, then if I decrease the PRF, I'm going to get a lasing. So do not touch PRF if you see color. Now, why we do not see color quite often in gynae studies is, in gynae, we're dealing with low velocity flow, number one, thin vessels. So low velocity flow can be picked up only on power Doppler, can be picked up at a lower PRF. Now, even after adjusting PRF to 0.3 to 0.5 and the color gain also, we increase the color gain, we don't see color, then remember the dictum in Doppler is, if I have to see a vessel, that vessel should be perpendicular to my ultrasound beam. Now, there are no angles displayed to show me whether it's perpendicular, parallel, or oblique. So in that case, what do? I'll do slide probe rotation and then I'll see color. So to answer your question, touch PRF when you don't see color. Or look at PRF when you see a lasing. If you've seen color, pure colors, do not touch the PRF.
Yes. Thank you. Thank you so much, ma'am. Ma'am, you did not speak in your talk. I did not find any slide on tubercular endometrium. Does it have any particular features? A patient with previous COX or an active tubercular endometritis?
See, any chronic endometritis are very non-specific findings. You can get a thin endometrium, you can get a thick endometrium. You can get no flow or increased flow. So the slide on endometritis is meant to cover all infections, not specifically tubercular.
Ma'am, when we do hysteroscopy, the classical feature of tubercular endometritis is supposed to be micropolyps, very small polypoidal structures on hysteroscopy. Can they be detected on a good 2D resolution of TBS?
No, as to my knowledge, the polyp, what we use on ultrasound, the term polyp is two. Endometrial polyp, three. Endometrial polyp, fibroid polyp, or polypoid endometrium. Now, polypoid endometrium is because the endometrium has proliferated so much that it's forming folds.
Yeah.
So I don't know how the micropolyp, I think interesting. In fact, if,
this is the hysteroscopic terminology which has come. I think many of the youngsters who are doing actively hysteroscopy now, like certain features which have been, denoted as hysteroscopic features of COX endometrium, ma'am. I'm not very sure. I'll have to read more about it.
Okay.
And yes, ma'am. Ma'am, you had mentioned something about a postmenopausal endometrium also having a thickness of 8 mm, 10 mm, 11 mm. So, ma'am, if we see a postmenopausal woman who is 10 years after menopause, and if we see an endometrium of 7 or 8 mm, does it mean it's okay?
See, one is you're talking about 10 millimeter or 7 millimeter thickness postmenopausally in a lady who's got no symptoms.
No symptoms.
Yeah. So what some of the guidelines I've read said that there's no need to act, provided, again, don't just look at thickness. If that postmenopausal endometrium looks homogeneous, that means uniform. It can be uniform, like a uniform hyperequic, uniform isoequic. There is no vascularity. Now, most people, or I would say all of us, can get caught in this vascularity angle because they are small vessels. So unless we spend time on the Doppler, diligently do our rotations, adjust the PRF, and then say no vascularity in the endometrium, then there is no need to act and just keep the lady on follow-up.
Right.
And also look at the EMJ.
Because, ma'am, once you report a thickness
Yeah, can I add something, Monica, here?
Yes, ma'am. Please.
Yeah, so thank you so much, Dr. Supriya. It was wonderful. But when talking about a thickened endometrium in postmenopause, I will be a little concerned for sure. And we'll take a history of whether she's obese, hypertensive, and diabetic. So in those cases, I think I will not hesitate to take a pupil biopsy in the OPD because that's not a very invasive procedure though. So I think that will be a safer procedure looking at the history of the patient if she's obese, diabetic. And as Dr. Supriya has mentioned, that the texture and the vascularity of the endometrium is also equally important. And look at the junctional zone. So I think when you have a thickened endometrium, you have to look at so many other things other than only the thickened endometrium.
Yeah, I agree with you. In fact, that was my last slide.
History
The
of
last
any
slide I
HRT,
remember.
or sometimes she's a case of CA breast on tamoxifen. So all those history has to be taken properly, and then I think if everything is okay, we can leave her alone.
Yeah.
Also, ma'am, in perimenopausal bleeding, I've seen that if associated adenomyosis is there, then we cannot just discriminately just take endometrium thickness as the sole marker. We have to take other comorbidities in the uterus as well, because
Because
with
endometrial
adenomyosis,
thickness is not clearly actually discernible when there is associated
and it
adenomyosis.
is thickened also at some places in adenomyotic
Yeah.
uterus. And we are not really thickness measurement. Endometrial thickness is not the only guide.
Yeah.
It's not the guide in any age group, any category, just the thickness. No report should stop only at thickness. It should
Now, since
describe
we
the
have those
entire
executive
endometrium.
health checkups, so in that executive health checkup, they have an ultrasound and come back with the thickened endometrium. So I think those are the cases actually where we have to think and take a call on that.
Really, Supriya ma'am, you have really opened the eyes of all of us who are doing scans. But now we will really look at the endometrium very nicely, ma'am. Thanks to your lecture. And ma'am, I must admit that you are one of the best speakers we've had in Synergy so far.
Thank you
In
very
fact,
much. Thank you.
in my lifetime, madam.
Thank you. Thank you.
So thank you so much, Supriya ma'am. And it will be
Thank you,
great
ma'am.
to
Thank you so much.
associate with you for further topics. If you are associated with Synergy, we'll be very, very grateful to you, madam. And thank you so much for your time and your deliberation, ma'am.
Thank you. Thank you.
I request Dr. Ankita Upadhyay to please start session 2.
Good evening to all. Now moving to the session 2 of the program, that is the current FIGO staging of endometrial carcinoma, a practical overview. And to chair the session, I invite all the elite speakers for the session, the chairpersons. The first is Dr. Alpana Agarwal ma'am, Dr. Deepti Chaturvedi ma'am, Dr. Abha Sapra ma'am, Dr. Latika Agarwal ma'am, and Dr. Prerna Agarwal ma'am. May I have the CVs, please? Dr. Alpana ma'am is the professor and medical superintendent at Santosh Medical College and Hospital, Ghaziabad. She is the president of Ghaziabad Obs-Gynae Society. Madam has various publications to her credit, and Madam has won the Global Teacher Award of 2021. We welcome you, ma'am. Next, we have Dr. Deepti Chaturvedi. Ma'am is president of Gorakhpur Obs-Gynae Society. Ma'am is the coordinator at Foxy Gynae Onco Committee. She is a very active member of IMA and Foxy and has won many awards due to her work. We welcome you, ma'am. Next, we have Dr. Abha Sapra ma'am. Ma'am is president of Albar Obs-Gynae Society. Ma'am is working at Sapra Hospital at Alwar, Rajasthan, and she's a senior academician and she has an experience of over 3 decades. We welcome you, ma'am. Next, we have Dr. Latika Agarwal ma'am. Ma'am is president of Bareilly Obs-Gynae Society, and madam is an accomplished senior gynecologist at Sarthak Test Tube Baby Center, Bareilly, and madam has many awards to her credit. We welcome you, ma'am. Next, we have Dr. Prerna Agarwal ma'am. Ma'am is president of Mathura Obs-Gynae Society. She is a consultant gynecologist, ultrasonologist at Agarwal Nursing Home, Mathura. We welcome you, ma'am. I now would request the chairpersons to introduce our speaker for the session, Dr. Bhagya Lakshmi Nayak, ma'am.
So, Dr. Bhagya Lakshmi, she is MD, FICOG, PhD, and this is my pleasure and honor to introduce Dr. Bhagya Lakshmi Nayak. She is the Professor, Department of Gynecological Oncology, AHPGIG, Cuttack. She is the President, AOGIN India. She is the Honorary Secretary, AGOI, Chairperson, Oncology Committee, Foxy 2018-20. She is the Governing Council member. She was the Governing Council member, ICOG, from 2021 to 2024. Assistant Editor, Indian Journal of Gynae Oncology. peer reviewer, India Journal of Surgical Oncology, Jogi, BMC Cancer. More than 500 publications are she has already done, an editor of 3 books. And she got the awards Dr. Usha Sariyar Oration, Bhilai 2010, Dr. Abha Singh Oration, and Raipur 2019, Dr. Shireen Mehta Ji Guest Lecture Award, and Mumbai 2029, and Kamini Rao Oration on 2024. So this is the CV of Dr. Bhagyalakshmi. So stage is all yours. You can start your talk now.
Yeah. Thank you so much, Dr. Monica and team Bhopal, for having me here. And I should actually congratulate you that you are very much in sync with Foxy, because Foxy is always all inclusive. So thank you for getting so many societies along with this very nice meeting. And very nice to see all of you, Dr. Vartika, Dr. Jayabharti, and I think many new friends I have seen today. So Dr. Mrutyunjay, and thank you so much for giving me a talk which is so close to my heart, and you all will agree that it is really not a very easy topic to decide upon, because can you see my slide?
Yes, madam.
Yeah. So is it full screen now?
Yes, ma'am.
Okay. So I think we will talk about FIGO, endometrial cancer staging. So that is, I think those who have gone through the previous staging and now seen this new staging, I think there has been a very gross change in that. And so let us see what is the practical overview of that. So as you see, endometrial cancer would be a hypertensive, obese, postmenopausal woman, and she would have diabetes. And so it's so important that endometrial cancer is actually rising in the last few years. The incidence has been rising because of, I think you can understand, because of the rising incidence of obesity, rising incidence of PCOD. So endometrial cancers have been rising. So the 2023 FIGO staging system is markedly different, perhaps more complicated and elaborate than the prior version of 2009. So we are discussing about it now, and maybe very confusing sometimes to both patient and clinicians. So these are the authors of the FIGO new staging. So let's start with the case. So she's 54 years, postmenopausal, diagnosed with endometrioid adenocarcinoma grade 1, and a proper surgical staging was done as should be done for our endometrial cancers. And finally, it was seen that the primary tumor was less than 2 centimeter. It was a grade 2. The myoinvasion was less than 50%. There was no cervical stromal invasion. There was no LVSI. So she was actually given a low risk category, and hence no adjuvant treatment was given to her. Then she presented with a vault growth after 9 months, and the histopathology again from the vault growth showed that it was a grade 2 endometrioid adenocarcinoma. So did we go wrong anywhere? So she was actually a low grade, low risk patient and warranted no adjuvant treatment, but unfortunately she still recurred at 9 months. So I think we missed something there. So vault recurrence after 9 months, histopathology is grade 2, which is actually a non-aggressive variety. But now we had the thought of doing an IHC, and the IHC showed that there is a P53 aberration. So recurrence could have been avoided by adjuvant therapy if the IHC study would have been done earlier. So if you would have done the P53 IHC then a high risk factor is in early stage is a P53 mutation. P53 aberration molecular subtype is found up to 5% of grade 1 and 2 endometrial cancers, but it is a bad prognostic factor. Hence, there is enough rationality in integrating molecular features into pathology classification and stratification of endometrial cancer, but availability and affordability remains a little concern. So, call for improved classification system of endometrial cancer. It should be objective, reproducible, biologically informative to classify tumors as per biotypes, to enable precise risk stratification, and to modify management decisions. Hence, the molecular classification, which is integrated in FIGO 2023. So coming to staging of endometrial cancer, the goal of FIGO is to improve clarity of the diverse biological nature of the endometrial cancers with differing prognostic outcomes, better define these prognostic groups, and create substages that yield more appropriate surgical radiation and systemic therapies. Integration of other non-anatomical parameters such as tumor grade, lymphovascular invasion, and molecular alterations to provide a more personalized and relevant approach. The molecular classification and the new staging include Pol E mutation, MMRD, NSMP, and P53 aberration. So we'll talk about this in details in the subsequent slides. The molecular classification is an attempt to make staging more personalized and relevant to patient prognostication and management. So here you can see that in figure 2009, defined as tumor, stage 1 is defined as tumor confined to the uterine corpus, and it is subdivided into 1A and 1B according to the myometrial invasion, and a distinction between absent and less than 50% myometrial invasion is not necessary, they thought. But now in figure 2023, it is defined now by a combination of the following features: histological type, myometrial invasion, and LVSI. So lymphovascular space invasion is now become important in 2023 staging. So categorization as stage 1A versus 1B as defined in figure 2009 now only applies to non-aggressive histologic types with no or focal LVSI. For non-aggressive histological types with no or focal LVSI, reintroduces distinction between cancer confined to the endometrium, now 1A1, versus less than 50% myometrial invasion, now 1A2, versus more than 50% myometrial invasion is stage 1B. For aggressive histologic types, again, the staging is totally different and it is called a stage 1C and considers any myometrial invasion as stage 2C. So if there is no myometrial invasion, it is stage 1C. If there is any myometrial invasion, it is stage 2C. So then again, there is a stage 1A3, which is new in figure 2023. So I understand that it is a little confusing though, but then we have to know about it. So what is stage 1A3? Here, when the endometrium and the ovary both are involved, but introduces ovarian involvement as allowed if the following criteria are present. So it has to be a low-grade endometrioid type, absent or superficial myometrial invasion, absent or no LVSI, absence of additional metastasis, the ovarian tumor is unilateral, limited to the ovary, without capsule invasion or rupture. So it is called a stage 1A3. The similar thing will happen, it will become a stage 3A1 when both are involved, but it is a high-grade tumor. So we'll come to that subsequently. So when both are involved, the uterus and the ovary, but along with that, they have all good prognostic features, it is stage 1A3. Then coming to stage 2, in stage 2 in 2009, it was only one thing, which is cervical stromal invasion. But in stage 2, now in figure 2023, we have 3 stages. Stage 2 is now subdivided into 2A, where there is cervical stromal invasion, non-aggressive variety, 2B, substantial LVSI by non-aggressive histological type, and 2C is aggressive histological type with any myometrial invasion. So by non-aggressive, we mean FIGO grade 1 and 2, and aggressive histological types are FIGO grade 3 tumors, serous tumors, clear cell tumors, undifferentiated tumors, dedifferentiated mesonephric-like, gastrointestinal type, and carcinosarcoma. So there is a clear difference between non-aggressive and aggressive tumors. So similarly, coming to stage 3 again in figure 2009, it was 3A, 3B, and 3C, and 3C was divided into 3C1 and 3C2 according to the nodal involvement. But here in figure 2023, 3A again is now divided into 3A1 and 3A2, spread to ovary or fallopian tube, and 3A2 is involvement of the uterine subserosa or spread through uterine serosa, and this introduces the concept of the uterine subserosa. That's a new terminology here. 3B includes pelvic peritoneum, which was not there previously, and 3B1 is metastasis or direct spread to vagina and parametria, and 3B2 is metastasis to the pelvic peritoneum. But 3C1 again has pelvic nodal spread, 3C1 is micrometastasis, 3C1-2 is macrometastasis. Similarly, 3C2 is para-aortic nodal spread and is now divided into micrometastasis and macrometastasis. So now we know 1A3 and 3A1. 1A1 is both uterine and ovarian involvement, but with good prognostic factors. But 3A1 has both uterine and ovarian involvement, but with poor prognostic factors. So then coming to stage 4, a tumor involved in which the blood in 2009, it was bladder involvement and distant metastasis. 4A was tumor invasion of bladder and or bowel mucosa, and 4B is distant metastasis. But in figure 2023, now we have 4A, 4B, and 4C. 4A is involves bowel and bladder mucosa. 4B from the lungs, and 4C is any other like liver, brain, inguinal or extrapelvic lymph nodes above renal vessels. So what are the major changes that have happened? The increased number of substages from 10 to 23 and subdivisions in advanced stages from 6 to 11 subgroups based on anatomical site of the disease and histologic type. New terminologies are non-aggressive and aggressive varieties. Nodal metastasis is divided into now micrometastasis versus macrometastasis. Separation of patients with uterine corpus and ovarian involvement into two, stage 1A3, good prognosis, and stage 3A1, which is worse behavior. And criteria for good prognosis, we have already discussed. That is no more than superficial invasion, absence of LBSI, absence of additional metastasis, and the ovarian tumor is unilateral, limited to the ovary without capsule invasion or rupture. So major changes again are all aggressive cancers, if no extrauterine disease is present, are considered stage 2C unless they are limited to a polyp or the endometrium where it can be called a 1C or harbor a POLE mutation. So about POLE mutation, I'll be discussing shortly. The system also disregards other prognostic factors such as depth of invasion, cervical involvement, presence of LBSI for aggressive histologies, but includes them for non-aggressive histologies. So these are some of the differences that have happened in this 2023 staging. So the challenges to this is that we have lumped the aggressive histologies stage 2C, assuming that they have the same biological behavior. But it has been seen that in the absence of nodal metastasis or other extrauterine spread, clear cell carcinoma with one of 16 millimeter invasion and no LBSI, a serous carcinoma with 14 of 15 invasion and substantial LBSI, a grade 3 endometrioid carcinoma with 1 of 18 millimeter invasion, they are all different entities. So, and they are not likely to have similar outcomes. So these are some of the fallacies of the new staging system. So here comes the role of the molecular testing. So when FIGO 2023 endometrial cancer staging validation, welcome to the first molecular classifiers. So the molecular defined prognostic risk factors in FIGO 2023 stage 1 and 2 endometrial cancer especially, we need to do the molecular classification. So stage 1A, M means the molecular marker has been done and it has a POLE mutation. And stage 2, C, M means a molecular classification has been done to it and it is a P53 aberration. These are much less complicated than the ESGO Estro ESP classification. So this is what they claim. It is believed that for the molecular-based risk group allocation and planning of adjuvant therapy, the FIGO 2023 molecular staging system is more straightforward than the ESGO Estro ESP classification. So that is what they claim. So there are some advantages. We now have non-aggressive and aggressive. Stage 1A is low risk and 1B is intermediate risk. So there is a lot of precision in the risk stratification because there are too many subclassifications, molecular markers, all this has happened. So 2023 classification has advantages. Similarly, if we have a POLE mutation in stage 1 and 2, it is a low risk. If we have a P53 aberration, it is a high risk except for 1C. And aggressive tumor, these are staged under either 1C or 2C. In early stage, high risk except stage 1C if it has a POLE mutation. POLE mutation, we have to assume that if there is a POLE mutation, it is a very good prognostic indicator. And LBSI is disregarded in aggressive tumors. So LBSI is important, but it is not taken into consideration when we are looking at aggressive tumors. So low-grade endometrioid cancer, 1A, 1B. High-grade endometrioid cancers are 1C or 2C. When cervical stroma and low-grade, it is 2A. Similarly, LVSI and low-grade are 2B. So these are little confusing, but then we have to look up to the net every time you get a case of a new endometrial cancer. So then FIGO endometrial cancer stage with molecular classification. When molecular classification can be included, then stage designation sometimes would change. Molecular findings in patients with endometrial cancer stages 1 and 2 after surgical staging. So we have already done a surgical staging and now we are doing a molecular marker study. So if it is a 1A, but there is a POLE mutation endometrial cancer confined to the uterine corpus or with cervical extension, regardless of the degree of LBSI or histological type. So this is a stage 1A-M. So similarly, stage 2C-M, if it has a P53 mutation. So P53 aberrant endometrial carcinoma confined to the uterine corpus with any myometrial invasion with or without cervical invasion and regardless of the degree of LVSI or histological type. No specific molecular profile. So this is called NSMP and MMRD molecular subtypes mismatch repair deficiency. MMRD is mismatch repair deficiency. That is yet another molecular group. Do not affect tumor staging. And management depends on surgico-pathological risk factors only. So NSNP is the most challenging decision for adjuvant treatment, and adjuvant treatment is difficult. So pole mutation and P53 can change the stage, but NSMP and MMRD do not change the stage. However, we need to take it into consideration to plan adjuvant treatment. So pathological evaluation is also very important. You cannot just disregard this in view of the molecular markers. So from the uterus, what we want to see? We want to see the type of the tumor, the grade of the tumor, the ratio of the depth of myometrial invasion to myometrial thickness. From the cervix, so all this you have to know so that you have to dictate your pathologist to give you the reports accordingly. So if you, from the cervix, they have to tell you whether the cervix is involved or not, and the tumor size, tumor location, whether it is from the fundus or the lower uterine segment. What is the histologic subtype? What is the grade? What is the lymphovascular space invasion? This is also in the cervix. What is the fallopian tube and ovary status? Whether peritoneal cytology is positive or not. And if nodes have been resected, level of nodal involvement, that is pelvic, common iliac or parotid, which are the nodal group which are positive. Size of the metastasis, whether it is a isolated tumor cell, micrometastasis or macrometastasis. And finally, a complete molecular classification with polymutation, MMRD, NSMP, P53 aberration is encouraged in all cases of endometrial cancer for prognostic risk group stratification, and this can be done on a pre-operative biopsy specimen, and this is more ideal if you do it on a pre-op biopsy specimen before you do your surgical staging, because sometimes if it is just a polyp, there may not be any tissue left for molecular testing in the post-operative specimen. And coming to the histological types, endometrioid is 75% of cases. It could be well, moderate or poorly differentiated. And serous cancers are 10% of cases. They are aggressive with propensity for myometrial and peritoneal spread. Clear cell are 4% and aggressive. Mucinous are 1% and behave like endometrioid. And mixed, 2 common extragenital sites are breast, stomach, also colon, pancreas and kidney can also have metastasis. So coming to lymphovascular space invasion, what does that mean? Lymphovascular space invasion is defined as the presence of tumor cells in a space lined by endothelial cells outside the immediate invasive border and includes tumor invasion in both lymph and blood vessels. So in stage 1, it is ideally 10%, stage 2 is 30%, and as the stage increases, the LVSI increases. So LVSI can be difficult to distinguish from retraction artifacts or a so-called microcystic, elongated and fragmented pattern of invasion. Substantial LVSI is when more than 5 vessels are involved. So this is what your pathologist has to report, because substantial LVSI is a bad prognostic factor and actually upgrades it to a high risk category. So grading again is grade 1, grade 2 and grade 3, and grade 3 endometrial cancers and serous clear cell are all high grade tumors. This we have discussed. So grading is essential in NSMP endometrioid cancers, but it is not essential in mismatch repair deficiency cases. MMRD and polymutation endometrioid cancers can seem high grade because of their frequent mutations. So the mutation numbers are high in these tumors, so they may appear high grade, but they are actually not. Nuclear atypia in an architecturally low-grade endometrioid carcinoma should be evaluated P53 to rule out serous cancers and carcinosarcomas. So here I show you a picture of grade 1 endometrioid adenocarcinoma, a grade 3 endometrioid adenocarcinoma with abundant tumor infiltrating lymphocytes, and a serous-like feature with tumor giant cells. These are 3 endometrial cancers with different histological appearance. However, they belong to the same molecular classification. When polymutation was done in these tumors, all of them showed polymutation. So that means they carried a good prognosis. So when we have a polymutation, we could have a grade 1, we could have a grade 3, we could also have a serous tumor. So coming to myoinvasion again, percentage of myometrial involved should be expressed as the percentage less than 50% or more than 50%. The assessment of tumor invasion from adenomyosis is a controversial issue without strong scientific evidence. Then coming to molecular classification of endometrial cancer, there are various systems by which we can do. So in 2013, the TCG or the Cancer Genome Atlas research actually did the first research on this and found out these molecular aberrations. So poly mutated was found in 4 to 12%. MSI unstable or hypermutated, which is MMRD otherwise, is 23 to 36%. Copy number low, which is type 1 microsatellite stable, is 30 to 60%, and copy number high is predominantly serous, and the P53 aberrant variety is 8 to 24%. So this provides significant prognostic and potential therapeutic information. Poly ultra-mutated tumors have a best disease-free survival. Copy number high tumors have the worst disease-free survival. The other two groups, that is NSMP and MMRD, are the intermediate disease-free survival. So this is again a variability in endometrial carcinoma pathology practices, opportunities for improvement in molecular classification, where you can see that all the molecular markers can be there in all the histopathological types. We could have in endometrial low grade also, we could have poly, NSMP, MMRD and P53. In endometrial high grade, again, we could have everything. But you can see that in serous tumors, which are bad prognostic, the P53 aberration numbers are very high. Similarly, in carcinosarcoma and in mixed and clear cell and dedifferentiated tumors. But you can see that in endometrial low grade, NSMP is high. In endometrial high grade, again, P53 and NSMP are same to same. So TCGA project employs a combination of whole genome sequencing, exome sequencing, microsatellite instability assays, and copy number analysis. It's expensive, complex, unsuitable for wider clinical application. To overcome these issues, a simple, inexpensive, and clinically usable molecular classification system is now developed, which is called PROMIS, which is Proactive Molecular Risk Classifier for Endometrial Cancer. This uses IHC. IHC is common now and can be done in most of the labs except for poly only. So IHC stands to detect MMR proteins PMS2 and MSH6 and P53 aberration, whether it's aberrant or wild type, and digital PCR to detect polyexonuclease domain mutation. The resultant molecular subtypes are termed polymutant, which is surrogate of poly, MMRD surrogate of MSI, P53 wild type or NSMP are surrogate of copy number low, and P53 aberrant is surrogate of copy number high. So abnormal P53 mutation time is characterized by either strong nuclear expression. How do you tell that it is P53 aberrant? So it has a strong nuclear expression in tumor cells, which should be more than 80%, or the complete absence of expression in tumor cells with retained internal control, which is called otherwise called a null type, or rarely it could be an unequivocal cytoplasmic expression. So when you tell P53 aberrant, there are three varieties to it. So this surrogate marker approach to the molecular based classification been demonstrated to be prognostically informative in low, intermediate and high risk endometrial cancers. To note, the molecular surrogate is not perfect. So please remember, it may not be perfect. IHC demonstration of P53 aberration is a good but not perfect surrogate of the tumor P53 mutation. A small proportion of high copy number tumors do not show P53 mutations. Molecular classification is mostly applicable in high-grade endometrioid cancers, but applied to all endometrial cancers. Smaller studies showed that the molecular classification also applies to non-endometrioid tumors, including serous, clear cell, and undifferentiated. For adjuvant treatment recommendations, molecular classification seems to be particularly relevant in high-grade and or high-risk endometrial cancers. So these are again WHO classification of the endometrial carcinoma. So the new classification has also taken into account all the molecular markers. So integration of molecular parameters into standard pathology reporting by WHO 2020. So it is imperative that the world is now aware of the rationale for molecular subtype specific classification. So when you have an endometrial cancer, you could go anyway, but you have facilities do the poly sequencing first. If there is no poly hotspot mutation, then we do a DNA MMR protein immunohistochemistry. If the expression is lost, it is called a MSI high. So if the expression is retained, then we do a P53 IHC. If it is normal or wild type, it is copy number low. And if the poly sequencing has a mutation, that means it's a good prognosis. It is called a polymutant tumor. So then these are molecular and clinical pathological features of endometrial cancer according to the polymutation dMMR, that is MMR deficiency, NSMP and P53 aberration. So I think these are a little more details about it. So I think we may miss this notations for molecular subtypes. So this let us see a case actually. So here was a hysterectomy specimen deemed to have a grade 2 endometrioid carcinoma with invasion into the outer half of the myometrium. On review at local cancer center where the tumor is considered grade 3 and therefore assigned FIGO stage 2C. So when it was reviewed again, so they told it's a grade 3, it's not grade 2. So when molecular classification, so it became a stage 2C then. So when molecular classification results became available and a pathogenic polymutation is identified, the same patient was the stage again changed to stage 1AM polymutant. So now she becomes a good prognostic factor. There's a good prognostic tumor. So she may not need any adjuvant treatment. So I think there is a lot of stage shift as we enter into this arena. Similarly, this is a patient with surgery at one institution. Their pathologic diagnosis is grade 2 endometrioid adenocarcinoma with 3 of 15 millimeter invasion, no LVSI, nodes negative. So according to 2023, she is stage 1A2. The same patient goes to another institution for a second opinion and the pathologist there diagnoses her tumor as grade 3 endometrioid cancer. So she becomes 2C. She goes elsewhere for a third opinion. The institution offers molecular testing and a tumor is found to harbor a polymutation. So all these complications can happen. So we have to be very thorough in our knowledge about how to assign a proper stage to this patient. Patient has surgery. This is yet again another patient who had a surgery diagnosed with grade 2 endometrioid adenocarcinoma with 1 millimeter myoinvasion, no NVSI and negative nodes. The treating institution performs a P53 IHC but does not offer polymutational assessment because poly is a challenging test. It needs a NGS and all institutions may not have it. So her tumor is deemed now as P53 abnormal. So she has stage 2C. M means molecularly classified as P53 aberrant, which is a high-risk disease. The patient then goes to another institution that offers poly testing and she is found to have a polymutation. She now has a stage 1A M polymutated disease. So polymutation means she is a good prognostic disease. She will not need any adjuvant treatment. So I think there's a lot of confusion as we learn more and more about the FIGO new staging. So I think there's a lot of confusion about that. So as we are able to understand, access more and more molecular testings, then we can actually give a clear-cut message to our patients. So FIGO does not recommend the management. So FIGO only gives us the stage. It does not recommend any management of the endometrial cancer according to the stage. Then we again have to depend on the ESCO, ESTRO, ESP guidelines till any guideline issues FIGO gives any more guidelines. So I think the management part, we are not going to enter into that complications. It is a lot of confusion in that. So we now understand that FIGO staging is very precise. It gives us too many substages, and there we have to look at the grade of the disease. We have to look at the molecular marker. We have to look at the LVSI. So all these things taken together, I think we will have to plan the treatment. So MIS is preferred in endometrial cancers. Avoid intraperitoneal spillage. But then we have to confirm that there is no disease outside the uterus. Omentectomy can be avoided. Lymph node assessment needs to be done except only in stage 1A1 when we may not do when there is no myoinvasion. Ovarian preservation can be done in early stages when she is less than 45 years, and especially if you have a molecular marker which shows that it is a good prognosis, you can do a ovarian preservation in very young women. And fertility preservation also follows the same things, that you confirm the stage of the disease. There should be no LVSI. It should not be a P53 aberrant tumor. Then you can still go ahead with the fertility preservation. So, and radicality of the surgery, again, we should do when we are planning for a surgery, plan for a stage 1 and 2 simple extrafacial hysterectomy is good enough, and a more advanced surgery is only done if there is cervical extension or more extrauterine disease. So adjuvant treatment, we have to risk stratify them: low risk, intermediate risk, high intermediate risk, and high risk, and plan your adjuvant treatment accordingly. So it is a stage 1 in low risk disease, no adjuvant treatment is recommended. In intermediate risk, adjuvant brachytherapy can be recommended to decrease vaginal recurrence. Omission of adjuvant brachytherapy can be considered, especially for patients aged less than 60 years. And similarly, in high intermediate risk, adjuvant EBRT is recommended, and adjuvant brachytherapy for stage 2A grade 1 endometrioid cancers. And in high risk disease, we recommend EBRT with concurrent and adjuvant chemotherapy, sequential chemotherapy, and EBRT, and chemotherapy alone. So all these are choices. And there is one thing that even if she is a high risk, but she has a polymutation, we may de-escalate the treatment. But then that's again with a pinch of salt, that if he doesn't have any high risk features, then maybe we can think of de-escalation, which is not the standard of care now. So adjuvant treatment of high risk endometrial cancer, we have so many options in hand: EBRT with concurrent adjuvant chemotherapy, alternatively sequential chemotherapy. And in advanced disease, I think there is no scope of any de-escalation in spite of all molecular markers. We have to give primary surgery or delayed surgery along with systemic chemotherapy, EBRT, and there is some role of pembrolizumab or in the form of immunotherapy also. So sometimes we could also get unstaged patients. We have endometrial cancer which has just undergone a simple hysterectomy. So if revision staging is not done, then we have to give EBRT in stage 2A and 2B, or chemo radiation if she has aggressive tumor, or brachytherapy if we can confirm that she's a stage 1A1 with a grade 1. Because we now have very good imaging modalities and molecular stratification, we can plan some kind of surgery also, revision surgery, if that is required. So when molecular classification is known, risk stratification is denoted according to the detection of molecular risk category. With stages, management is directed accordingly. So again, this is how we can go about it. So I have already told this. We do a poly test first. If poly is pathogenic, it's called pathogenic, but the prognosis is the best. But if poly is wild, we do a MMRD and call it as a MMR deficient. If she's MMR proficient, then we do a P53 mutation. If it is a P53 mutant, she's P53 mutant. If P53 wild, we call it as a NSMP tumor, or no specific molecular profiling. So I think there are so many other things which have been added to it in the last so many years. So I don't want to confuse you too much. So future directions, we need more evidence on selecting adjuvant radiotherapy now, chemotherapy and targeted therapy based on molecular alterations in EC endometrial cancer is needed. Results of ongoing and future trials investigating adjuvant and targeted therapies for endometrial cancer are eagerly awaited. And there are so many trials which we are waiting for. So let me not confuse you more. So I think what I have told, please remember all those things. And just if you have access to any IHC, the immediate ones, which is the urgent ones, are ER, PR, and P53. So these are the 3 immediate IHC markers that must be done. The rest are again luxury. If you could do MMRD, it's good. If you could do P53 poly mutation, that is good. And there's so many other markers which are also coming up, which are actionable. We can plan immunotherapy according to that. But at least from the pre-biopsy specimen, please order a ER, PR, and P53. A P53 wild type means it's a benign thing. P53 wild type means it has a good prognosis. If it is a P53 mutant, it is a high-risk tumor. So if it is better to send her to a center which has facilities for a proper staging and proper adjuvant therapy. So I think I should stop here in the interest of time. So thank you very much for giving me this opportunity.
Chairpersons?
Would be happy to take any questions.
No questions. Only this ma'am has really done wonderful job by explaining it in such a detail. And yes, this is true that alone biopsy or histopathology, as in olden days we used to do, is not sufficient. Nowadays they are doing IHC markers, in which all these details which ma'am has said, they give. But still, sometimes like when they do CT scan or MRI and not able to tell about the staging, proper staging. So peritoneal washings, and they say, must also be taken. Like if there are some spilled cancer cells, that also can be picked up in that peritoneal washings. And accordingly, like many times, the pathologist is not also an expert, and many times the tissue it's hiding somewhere, and they have taken the piece from some other place. So also there is a recurrence. So it's always better only in the stage 1. It's okay, do a surgery, but I think, it's my personal opinion, as ma'am has said, brachytherapy and external beam radiotherapy and adjuvant therapy as per the IHC report, molecular report should be given. So that's really wonderful, and it's extending so much, especially where
it's too much for general gynecologists, but I think you should know that all this should be done, and wherever available, we should make use of all these things.
fertility is also a concern, because
Yeah.
now they are marrying late and they are having बच्चे होने से पहले ही उन्हें पता चल गया कि she is suffering. So then what you have to do?
Infertility workup also we get the report of endometrial cancer. So then it becomes a real fix whether to do a hysterectomy, do a fertility preservation. So I think there again molecular markers have a real role to play.
Yes.
So if we have all the good prognostic ones, we can convince the patient that we can give a trial of progesterone and a Mirena and do a biopsy every 3 months and see. Otherwise, if it is P53 mutant, I think it's very risky to consider fertility preservation, and similarly ovarian preservation. High risk cases, we don't recommend ovarian preservation even if they are early stages.
Yeah, if it is low risk and she wants to preserve her uterus, we won't do surgery, but how long will we give progesterone?
Yeah, when we actually, in my practice, I add metformin also, because that's an insulin sensitizer and somehow it has anti-apoptotic effects. I give progesterone high dose, and along with that, I also give a Mirena. So having said that, every 3 months we have to do a hysteroscopic guided biopsy with the Mirena in situ, so that we see whether it is progressing or regressing. So we can do it 2 times. Suppose I do it after 3 months, I see it's negative. I repeat it after 3 months, again it's negative. Then I can send her for a IVF specialist for pregnancy to happen very fast, because I don't want to leave her alone, because the disease will come back again. But if she's still positive, maximum for 1 year. If the disease does not regress within 1 year, I think we have to explain to the patient that this is not going to happen. But in the meantime, we could do some kind of, if she's married, embryo preservation and surrogacy later, or we can do oocyte preservation also before we go for some surgery.
Thank you so much.
So in such cases, ma'am, you can do ovarian stimulation with gonadotropins.
And then
Yes,
then preserve it, no?
That's a good question, but then we have to keep the estradiol levels not very, very high.
Not very high.
Yeah.
Anti-estrogen drugs.
Controlled ovarian stimulation.
The aim of the fertility specialist is to freeze as many embryos as possible, but we have to keep the dose of gonadotropins low. In that case, we might not get a supraphysiological number of follicles, but maybe sufficient to just freeze and preserve. And there also, it will be better if you freeze in such fertility.
You can't freeze the embryos. You can freeze the. There are many places who are doing oocyte preservation.
Yes, madam. But
Actually,
if she's married,
Yeah.
embryo
like
would
to
be better.
interrupt, it is like we can always start a random start protocol in these patients of whenever they are diagnosed with any sort of CA, and then we should always give low dose of estrogen, like we always add letrozole to it or clomiphene, so that the estrogen level doesn't rise very high.
Yeah.
So that really creates whether it's a good thing for the patients, and that keeps the estrogen level in check also.
Yeah, letrozole,
You can do
gonadotropin.
serum estradiol.
Yeah, we all that will be done, of course, when we do the monitoring of the cycle. Otherwise, we always add letrozole in these cycles, and we do random start protocol.
to
And
collect
the
as well,
IBS
you said,
specialist
and
will
as
send the
soon as
patient 10
possible.
times to us. Get a clearance from oncologist madam. Get a clearance from oncologist madam. Then only I will do the IVF.
Yeah.
Yeah, that is very
In
important
fact,
cause.
ma'am, these fertility preservation for onco patients is now on the rise.
Yes.
Yeah,
Almost
it is very
every
much on
month
the
we are
rise.
getting 2 patients for
But once family is
postpartum.
complete, it is ideal to go ahead and do a hysterectomy. But some
Yeah,
patients sometimes they don't agree because they think that it's all gone. Why should I get a hysterectomy done? But then they'll always be running the risk because the same milieu is there, the same
yeah.
genetic factors are playing.
Yes, ma'am.
Many patients, ma'am, हम लोगों के पास आते हैं कि even after treatment, like like you said, na, they don't want to go for hysterectomy. No, in CA especially, cancer cervix, not endometrium, I'm talking. Even if if it has all gone off by radiotherapy and other drugs, still they say, "अरे ma'am, अभी operation क्यों नहीं किया?" Like in we do Vadaim, and we do total hysterectomy or pan hysterectomy only up till 2A, second A, but they want even in third and fourth stage. Like with radiotherapy or chemo, we do in the later stages.
Yeah, that's a
But
little lack of
they say,
knowledge.
no, they say कि it is still
think,
there inside me. The disease is still
They
there.
want the organ out. So
Out.
it's a psychological thing that we had the organ cancer out of me.
It is beyond the guidelines. Then what you have to do for
Yeah.
how you go by
Yes.
the guidelines? How can you go? Exactly.
No, I think we have to counsel them a lot that hysterectomy is not going to help. But then there have been instances where the radiation oncologist actually send the patient for adjuvant hysterectomy sometimes. So if they are in a doubt, there is a slight focus in arrest which has been left behind, the radiation has not responded. So in those cases, actually, we have done adjuvant hysterectomy in some cases where the radiation oncologist actually is not very sure in infiltrating lesions, especially in the endocervix, where they think that there could be a little focus inside the endocervix, which will come back later. So they sometimes exophatic growths are good. They respond very well to radiation. They will melt in front of your eyes. But if endocervix
If they don't do brachy, if they don't do brachy,
Yeah.
tendons are gone inside the cervix. When they don't do brachy, that must be the reason. I think so. It is kind for because that will only cause recurrence. So thank you, ma'am. It was such a nice detailing and crisp, informative, and elaborative lecture, and it just bridged up all the gaps of
No,
knowledge.
but just this is a disclaimer that this 2023 stage is actually undergoing changes because there's a lot of feedback from many people that it's quite a confusing thing.
Yes.
So I think there's a lot of
But
change again
like
which is
what
going to
we,
happen, and then we are
I'm telling you, like for India, developing world, we are studying things of the developed world. So it's okay to be little broad in our thinking. That
we do ERPR P53. I think that's the
Yeah,
best thing
बस.
because ERPR is positive means it's a good
Staging
prognosis
इतना नहीं चिंता
because it
करिए.
is still
should go for
yeah,
molecular.
ERPR 53 ये 3 is available everywhere. IHC not very costly because ERPR अगर express होता है तो the endometrium is a good endometrium and is akin to the endometrium that was
It will respond to
P53 वो
the
तो
hormonal.
आराम से पता चल P53 aberrant is a bad prognostic tumor.
Yes. Basically,
Even
ER
if
and
it is a
PR
small
positive
tumor,
means
it will behave badly.
differentiated endometrium. Yes, ma'am. So, ma'am, that was a very, very elaborate lecture, and Dr. Dipti and your conversation and interaction was very educative for all of us. This is because of the huge amount of gynec onco work that Dr. Dipti Chaturvedi and Dr. A.K. Chaturvedi, madam, sir, are doing in Gorakhpur. So, madam, please keep up your academic interests and keep sharing your cases with us so that we all can benefit. And now I think it's time to thank both our keynote speakers and move to session 3. And because all our panelists are waiting, I request Dr. Virul Srivastava and Dr. Ankita to please conduct the panel discussion.
Good evening,
Thank you,
everyone.
nice madam. Thank you.
Good evening, everyone. Now we are proceeding with the session 3, that is panel discussion. And topic for the panel discussion is endometrial pathology and smart diagnosis. See, we have the moderator for the panel discussions are Dr. Jaya Bharti ma'am and Dr. Monica Singh ma'am. Can we have the slide, please? So Dr. Jaya Bharti ma'am is the president in Bhadrachalam Obsgynec Society, Telangana state. She has done her MBBS and MD both from Karnal, AP, and she was a gold medalist over there. She is also an FMF certified. And presently she is working in Jaya Bharti Multi Speciality Hospital, Bhadrachalam, Telangana. We welcome you, ma'am. Now, second moderator is Dr. Monica Singh, ma'am. She is the whole soul of our synergy and also the convener. We welcome you, ma'am.
Thank you, thank you, thank you.
Here are the list of our
To the-
panelists.
Yeah, coming to the galaxy of the panelists that we have today. First of all, I welcome Dr. Aditi Rathore, ma'am. Madam is the secretary of Ratlam Obsgynae Society. She is a consultant at Rathore Nursing Home, Jaora. We welcome you, ma'am.
Second panelist, we have Dr. Charu Johri, ma'am. She is a gynecologist and consultant at infertility specialist at Indra IVF Alwar. We welcome you, ma'am.
Next, we have Dr. Komal Jain, ma'am. Ma'am is the secretary of Jabalpur Obsgynae Society, and she is currently working as director and consultant at KG Memorial Hospital, Jabalpur. We welcome you, ma'am.
Our next panelist is Dr. Manju Singla, ma'am. And currently, she is doing private practice at Singla Hospital for the last 22 years. And she is a presently secretary of Ludhiana Obsgynaec Society and member of Foxy MTP committee. We welcome you, ma'am.
Next, we have Dr. Prerna Agarwal, ma'am. She is president of Firozabad Obsgynae Society, and madam has been a practicing consultant and doing ultrasound for more than 3 past decades. Madam has received many awards to her credit. We welcome you, ma'am.
Next, we have Dr. Priyanka Agarwal, ma'am. She's a secretary of Firozabad Obsgynaec Society. Unfortunately, ma'am is not able to join our session. Thank you.
Next, we have Dr. Priyanshu Patel, sir. Sir is the secretary of Mehsana Obsgynae Society, and sir has been an active member at many societies and is involved in social activities too. We welcome you, sir.
Next, I would like to welcome Dr. Rahul Patel, sir. She is a consultant obstetrician and laparoscopy specialist. He is associate professor at Banas Medical Palanpur and also a secretary of Palanpur Obsgynaec Society. We welcome you, sir.
Next, we have Dr. Rekha Wadhwani, ma'am. Ma'am is an active member of Bhopal Obsgynae Society. She is the former vice president and current executive member of BOX. Madam is professor at Gandhi Medical College, Bhopal, currently. We welcome you, ma'am.
Last, we have Dr. Shijal Dayal, ma'am. She is a radiologist and she also not able to join our for the session because she is busy.
Next, we have Dr. Shubha Singh, ma'am. Ma'am is president of Jaunpur Obsgynae Society, and madam is one of the founder member of Jaunpur Obsgynae Society. Madam is the director at various institutes and various schools at Jaunpur. We welcome you, ma'am.
Next, we have Dr. Sunita Badani, ma'am. She is a president at Ratlam Obsgynaec Society and also a director and consultant at Ratlam Hospital Research Center. We welcome you, ma'am.
We now hand over the session to Dr. Jaya Bharati, ma'am, and Dr. Monica Singh, ma'am, for further moderation.
Welcome, Jaya ma'am. Ma'am, you can start.
Yeah, I'm sharing my screen. Is my screen visible?
Yes, ma'am. Yes, ma'am.
Is my pointer visible?
Yeah, yeah.
Yes,
Yeah.
ma'am.
Thank you very much for inviting me to this Synergy webinar. So we'll start with the panel discussion. The endometrium, already we have heard a lot from Dr. Seshadri ma'am and Bhagyalakshmi ma'am. Excuse me. I'm unable to see this full screen. The images are blocking my screen.
Ma'am, you can minimize the images, but then you will not be able to see the panelists.
That is
There
what.
is a view, there is a view at the top right corner of your computer screen. There is a view. Yes, ma'am. If you click on the view, you will get a standard view as well as the side-by-side view. Studio, can you help, madam?
Ma'am, at the bottom right hand, can you see that percentage thing? Yeah, just click on the left button, the one with the note. Am I audible, ma'am?
Yeah, I got it.
Still, it is not into full screen. Yeah, this is good to go. Just don't press escape, ma'am. If you press escape, then it will come out of the full screen mode.
Yeah, then it's only a small screen for me. Even for you, I think. It's not in full screen.
Click on the small screen, it will become big.
No, it's the images are blocking my screen.
Ma'am, you can stop share and share again, I think. Try stop sharing and then share once again. Ma'am, first bring your open PPT to your desktop.
Yeah. Already open. I'm on.
Yes, ma'am. You can try once more.
No, same problem. It's been the same thing for me.
No, ma'am, just move the slide. This is good. Just move your slides. Yeah, this is moving now.
Yeah, it's moving, but I am not seeing my screen full. The images of the panelists are obstructing my screen.
Just drag and drop on the right hand side, ma'am. Just drag them and drop it onto your right hand side.
Ma'am, drag the whole panelist panel and drag it to the one side of your
side where it is not obstructing your screen.
Okay. So anyway, you are seeing the full screen, huh?
Yeah.
Yes, ma'am.
Okay. We'll start. The endometrial pathology and smart diagnosis. Thank you, Monica, for this prefix. It is smart diagnosis. To make the diagnosis smart, you also need many smart tools. Okay, I am myself Dr. Jayabhati as the moderator, and I have with me Dr. Monica as the co-moderator. So I welcome all the panelists, and let's start the show. My place is an abode of Lord Rama. I bring with me the blessings of Lord Rama for all of you. So to do a scan, a pelvic scan, first you should start with transabdominal scan so that you will have the orientation of the anatomy and the relationship of the pelvic organs. Of course, TVS is the gold standard. So whenever it is not possible to do a TVS, it is better you opt for TRUS, that is transrectal ultrasound. Well, what are all the prerequisites? You all know, just for completion's sake. Consent and privacy, of course. You ask her to empty the bladder. A lithotomy position on a gynae couch is ideal. It's always better to have a pillow under the hips, but no pillow under the head. Whenever you introduce the probe, you just slide the probe and no screwing movements. And if you want to exert any pressure, it should be only on the rectum. So if the screen is difficult, the visibility is limited, then place both the flexed knees over the abdomen. So this makes more room in the pelvis and easy for the probe movements. Well, for an ideal imaging, your ultrasound beam must be perpendicular to the endometrium. So then only you will have the optimum imaging. This is a high resolution transvaginal probe. You can see this mark on the probe, and this probe mark should face superior. That is, it should face the roof of the scanning room. And whenever you want to do rotational movements, It is always, always in anti-clockwise direction, right? So what is the orientation? So this is the orientation I am going to use in my presentation. So in the image, the footprint is above and the company logo is on the upper left side. So the wall of the uterus close to the footprint is anterior, away from the footprint is posterior. So this is again retroflexed, retroverted uterus. Here again the footprint is above and the company logo is on the left side. But here the wall that is close to the footprint is posterior, away from the footprint is anterior. So the second image is not the mirror image of the first one. Okay? If you agree for this, we'll proceed. So what are all the smart tools I use? It is a contrast enhanced like saline sonography, 3D surface mode, OmniView with VCI, 4D VCIA, color Doppler, power Doppler, glass body, cine volume, HD live silhouette, edit light, magic cut, and so on. The list is numerous. So in this, I'm going to use the IETA consensus. So most of the slides will be repetition of that of Dr. Seshadri's. Why IETA terminology? These are standardized terms, definitions, and measurements. Why? For the uniform description of sonographic features. When I say it is an endometrial polyp, it should be endometrial polyp for you, for him, for her, and for everyone. When I say it is endometrial hyperplasia, it should be endometrial hyperplasia to everyone. So this minimizes intra-observer and inter-observer variation. So coming to the terminology, the first one is endometrial echogenicity. We have two types in this, uniform and non-uniform. Coming to uniform, it is of 4 types, 3-layer pattern, hypoechoic, hyperechoic, and isoechoic. This all you have already seen in Dr. Seshadri's presentation. It is uniform linear, hypoechoic, hyperechoic, and isoechoic. And coming to non-uniform, it is a little bit confusing. So non-uniform is homogeneous with regular cis, irregular cis, heterogeneous without cis, heterogeneous with regular cis and irregular cis. So this is homogeneous regular cis, homogeneous irregular cis, heterogeneous without cis, heterogeneous with regular cis, heterogeneous with irregular cis. So this is very important. This is bright edge sign. So this is the interface between the intracavitary lesion and the hyperechoic endometrial margin. So what is the endometrial midline? So we see it as a linear midline. We see it as a non-linear or wavy. It is interrupted here and there is no midline here. So Dr. Aditi, this image is for you. Please try to interpret this. Is this a uniform or non-uniform? Dr. Aditi.
Yes, ma'am. Good evening, ma'am.
Yeah.
Yeah, ma'am. It is a uniform endometrium.
Good. Is it homogeneous or heterogeneous?
Ma'am, it is a homogeneous uniform endometrium showing the triple layer structure.
Do you see the central line?
Yes, ma'am.
Yes. And do you see any cyst?
No, ma'am, there's no cyst. The endomyometrial junction is intact.
Do you see any fluid? Do you see any fluid?
No fluid.
Do you see any intracavitary mass?
No.
No. So this is a homogeneous, uniform homogeneous with central line.
Yes.
How do you measure the endometrium? I have given you this axial plane of the uterus. How do you measure endometrium in this image? Or do you require any other image?
Ma'am, I would like to do it in the linear way, not in the axial plane because it might give a false.
So you want a sagittal plane?
Yes, ma'am, sagittal
yes.
one.
Congratulations. So the endometrial thickness is always measured in sagittal plane. So how do you measure it?
Ma'am, from outer margin of the outer margin, and if there's any fluid inside, then I will measure both the sides and then.
No, measure in this image.
There's yes, ma'am. As we have already marked it from outer margin of the upper line to the outer margin of the lower line. In the
outer
maximum
margin.
thickness, at the where the maximum thickness is there.
Yeah. I'll just
Yes,
repeat. It is from the outer margin of the upper
Upper
hyperechoic line
yes,
to the outer margin of the lower hyperechoic line at the broadest.
this
Not towards the fundus or not towards the cervix. It should be at the broadest one.
Yes,
Good. So whenever there is fluid, now you tell me.
Yes, ma'am. As you have marked, we will take from the upper margin of the outer margin of the upper hyperechoic line to the lower margin, to the upper margin of the fluid. Then from the lower margin of the fluid to the outer margin of the lower hyperechoic line. Basically, we do not have to include the fluid in the endometrial thickness.
You should not. You sum it up and give it as
yes,
a
ma'am. Sum it
endometrial
up and
thickness.
tell. Yes, ma'am.
So this is how we measure the endometrium when there is any intracavitary fluid. So if you have difference in both the layers, the upper layer, that is anterior endometrial line, is thin and posterior line is thick. How do you measure it now?
Ma'am, we'll take an average basically.
We'll add. So when there is a differential thickness, you measure the both layers and you have to mention it in your report like that, anterior endometrium and posterior. I mean, both the thickness, you have to mention it separately. Okay, right. This is for Dr. Charu. How to measure an intracavitary lesion? How do you measure it? Dr. Charu.
Yes, ma'am. Good evening. So first we have to see where is the lesion. You are thinking about endometrial lesion, right?
How do you measure?
So we have to measure in the all the three directions, like length, width and height. All the three dimensions we should see of the lesion so that we can give a correct report.
Yeah. Anything in ultrasound, whatever it may be, it could be a cyst, it could be a mass, you have to measure it in 3 orthogonal planes. Okay, thank you for that. So please interpret this image, Dr. Charu.
This is a sagittal plane view of uterus showing showing the uniform image throughout the line, but there is fluid in the cavity also in this image.
Is it heterogeneous or homogeneous?
It's homogeneous only, but with the fluid in the cavity.
Do you see the center?
Pardon, ma'am?
Central line.
No, we cannot see because there is a fluid, so the central line is separated because of the fluid there.
Yes, there's no central line.
Voice.
Somebody using two devices.
Yeah, ma'am.
What happened?
Sound is echoing.
Not from mine. Because even your voice is echoing.
Studio, please
correct. Has to do.
Ronak, wait.
Everyone.
Yes. Hello.
Everything is
Echoing. Ronak, everything is echoing.
Yeah. Now it's okay.
Now it's okay, Vishal.
Okay.
So, Dr. Charu, there's no central.
Yes.
Do you find any?
Yes, we can see the fluid in the cavity, but there are no cysts. It is homogeneous endometrium throughout, except the fluid in the cavity.
Do you find fluid?
Yes.
Is there any cavitary lesion?
No lesion. We cannot see any lesion inside the fluid or the cavity.
So this is an endometrium. I still have that echo.
Yeah. Vishal, there's something wrong.
But you must have joined from 2 devices, ma'am. Actually, someone is joined.
I tried to mute them again and again, but they are unmuting themselves, ma'am.
No, so if anybody has got, now it's okay.
I've been doing this. I've been keeping on muting them, but they are unmuting themselves again and again.
So any of us, if they have two devices open, it will echo for everyone.
Yes, ma'am. It will echo for everyone.
But right now it's okay. I think Jaya ma'am, you can proceed.
Yeah, yeah. So this is a thickened endometrium with turbid fluid. Most probably this is a case of endometritis. So, Dr. Charu, can you describe the types of intracavitary fluid? So most of the time, we don't measure the fluid. We don't need. So how do you describe it?
So we have to see how much fluid is there. We should take the measurement, how much fluid is there in the cavity, and we should see if there is any lesion inside the fluid, if it is anechoic or hypoechoic, or it is like in this picture it was turbulent, so it was showing some infectious fluid. So what is the consistency we can see inside the fluid?
So that is what. The fluid is described under these headings only: anechoic, low-level echoes, ground glass, and mixed. Oh, this is for Dr. Komal. Dr. Komal? Dr. Komal, are you there?
No, madam, she is not there. Dr. Komal has not joined.
Who will take up this question? Dr. Manu.
Ma'am, we have got Dr.
Manu?
Yes, ma'am.
Yeah, Dr.
I will
Manu,
take up this question.
what is endomyojunction? So how do
Ma'am,
we
this
know?
is the interface between the endometrium and myometrium. Usually it is very well defined.
This is the endomyojunction. So how do you describe it? Could you please?
It is like a small thin halo around the endometrium, which is present between the endometrium and myometrium.
Yeah. Endomyojunction is a very thin sonographically hypogenic zone. It is a sonographically seen thing, not anatomically. It is a sonographically hypogenic zone surrounding the echogenic outline of the endometrium. We
Yes,
also
ma'am.
call this junctional zone.
Yes, ma'am. EM junction.
Yeah. So I'll show you the endomyojunction in coronal section also. So this is the thing. And you can see this in this coronal image. It is very well defined, a very thin hypoechoic line all around the endometrium. Well, I have given you this B mode image. Are you satisfied with this endomyojunction?
Yes, ma'am. It is very well defined. It is regular.
Yes. For this B mode, it is very well defined. I'll give you my 4D image. So this is very well defined. I'll give you the 4D image. Now you compare the things.
Now,
What do you
this is
see
not
here?
well defined. In the 4D image, it is
What
not
do you
well
see?
defined.
What do you see?
There is a hypoechoic lesion at the
There is
end
a
of.
myometrial cyst. There is a
Yes.
myometrial cyst.
This is myometrial cyst. Yes, this
Yeah,
is myometrial cyst.
this is smart diagnosis. Do you agree?
Yes, ma'am. Yes, ma'am.
Okay. This is again for you. So please interpret this image. Is it uniform or non-uniform?
Ma'am, in this, the junction is not well defined.
No. I'm not asking about EMJ. Is this endometrium uniform or non-uniform?
Endometrium is uniform.
Yes. Endometrium is uniform. Is it
Uniform.
homogeneous or heterogeneous?
It is homogeneous.
Good. What about the central line?
It is wavy. It is not linear.
Yes, it is wavy,
It is
non-linear.
wavy.
Non-linear. Do you find any cysts?
No, ma'am.
Yes.
Endometrial cavity is clear.
Yeah.
But EM junction
You
is
don't see
poorly
the
defined.
You don't see the cavity. Whenever you see a central line, you don't see the cavity.
Yes, ma'am. Yes, ma'am.
Is there any fluid?
No, there is no fluid.
There's no fluid. Do you find any intracavitary mass? No, there's no intracavitary.
No, it's not there.
Okay, this is for Dr. Prerana. Dr. Prerana, are you there?
No, ma'am. Dr. Prerna is not there.
Anybody? Priyanshu? Dr. Priyanshu?
No, ma'am. He's also not there.
Who is that? Dr. Rahul is there? Dr. Rekha?
Dr. Rekha, Dr. Charu, Dr.
Who is there? Sheetal is there?
No,
Dr.
ma'am.
Shubha.
Sheetal is
Ma'am, I am here.
Sheetal. Yes.
Okay.
Yes. Welcome, Sheetal. Please interpret this image. I'm not seeing you, Sheetal. Sheetal? Dr. Sheetal? Is she
Dr.
muted?
Sheetal, are you there? No, no, ma'am. She's not there. She's
Dr.
not there,
Shubha?
ma'am.
Dr.
Or-
Shubha, madam? Shubha, madam is also
No,
not there.
ma'am. Ma'am, the
Dr.
oh,
Sunita.
no, the
I
only
think
panelist there.
Sunita, Dr. Sunita, she is there. Yeah, welcome, Dr. Sunita.
Thank you.
Please interpret this image.
Yeah.
Is it uniform or non-uniform?
It is non-uniform. It is having a some kind of lesion in the upper part of the fundus.
No. That is the. So this is uniform endometrium.
Yeah, it is uniform, ma'am.
Is it homogeneous or heterogeneous?
Heterogeneous.
Good. What about the central line?
Central line is visible, but it is interrupted.
Yes, good. Interrupted central line.
Yeah.
Do you find any cysts?
No cyst, ma'am.
Yes. Do you find any fluid?
No fluid, ma'am.
Do you find any intracavitary lesion?
Yeah.
Yes, this is the intracavitary lesion.
Lesion, ma'am.
Thank you. Dr. Priyanka is also not there. Okay, please continue, Dr. Sheetal.
Yes.
We'll interpret this image. What about this? Is this uniform or non-uniform?
It is uniform outline is there, and it is heterogeneous.
But I say it is non-uniform because it is wavy. A little bit wavy. Okay. Even uniform is also accepted. Is it homogeneous or heterogeneous?
It is very much heterogeneous, ma'am.
What about the central line?
Central line is again missing in the upper part of the fundus.
Interrupted.
It is interrupted.
And do you find any cysts in this?
Yes.
Yes, there are small cysts.
Small cysts in
Cysts are seen. Any fluid?
No fluid is seen.
Any lesion?
Yes, lesion in the fundal area.
This is a hyperechoic intracavitary lesion.
Lesion is there.
Okay. Dr. Priyanshu is not there. And who will take? Dr. Aditi, will you take up this? Dr. Aditi?
Yes, ma'am. Yes, ma'am.
Please watch this video and then we'll interpret. Okay. Please interpret this. Your input.
Ma'am, it is
uniform or
it
non?
is a ma'am, it is uniform.
Good.
Yeah.
Is it
Then, ma'am,
homogeneous or heterogeneous?
Ma'am, it is basically, it must be heterogeneous only.
It must be not. It is. It is.
Ma'am, actually, there is this fluid, and the only portion I can see is homogeneous only.
It is heterogeneous.
Yes, ma'am.
There is some this is
Echogenicity is there, right?
different. This echogenicity is different.
Okay.
This is different. So it is heterogeneous.
Heterogeneous, right?
Yeah. What about the central line?
It is not there.
Yeah, we have two lines because both the endometrial lines are separated. So do you find
But ma'am,
any?
it is ma'am mentioning homogeneous in the.
Yeah, it is
Yes.
Sorry. It is heterogeneous.
Yeah.
So no central line. Okay.
Yeah.
Are there any fluid?
No cysts are there, ma'am.
Any fluid?
Yes, ma'am. The fluid is there.
How is the fluid?
Ma'am, the fluid is basically, there are no echoes. It's homogeneous. Anechoic. Yeah.
So what about the intracavitary lesion?
There was a intracavitary lesion is there, which is homogeneous without any cysts, I think, or there are microcysts.
There are no cysts.
No cysts, right.
It is a hyperechoic polyp.
Yeah.
It is arising from the endometrium because you can see the endomyojunction also.
Yes.
It's basically an endometrial polyp.
Okay.
So Dr. Rahul is also not there. Dr. Charu. We'll go for color. So we have
Color
I am
Doppler.
here. I am Dr. Rekha.
Rekha, you are
Good
here. Can
evening.
you
Yes,
please
ma'am.
take up this one?
Okay.
So now we'll go to color. We have various modalities: color Doppler, power Doppler, HD flow, radiant flow, and slow flow. So for the color to work into your hands, that must be very good settings. The box size must cover only the area of interest. The color gain should be optimum, so that there is no aliasing. PRF for all gynic scans is 0.3 to 0.6. Wall motion filter, always, it must be always low, ideally 30 Hertz for transvaginal sonography. Balance must be optimum so that you don't see any patchy color. So, Dr. Rekha, I'll ask you this. This is the color. Okay. What is color score? Please explain us.
It depends how much flow is there when we apply the Doppler,
Yes.
and we give the scoring. If there is no blood flow, then it is score 1. Minimal flow is 2. It is like iota only. In the same manner we describe here. So minimal, moderate, and abundant. If there is multiple flow, we also see whether it is chaotic or it is regular supply.
That is different. Score is different. Pattern is different. So this is score we have 1, 2, 3, 4. So please interrupt these images. 1. How do you
One,
score
madam, there is
image
no
1?
color. There is no color.
1 is similar to color score 1.
Color 1.
Image number 2.
Image number 2 is scattered vessels are seen, but they are not crossing
Score,
endomyometrial junction. Score 1.
What is score?
2, sorry.
Yeah. Image number 3.
Score 3.
Image number 4.
Score 4. There is abundant flow.
So abundant flow is score 4. It signifies abundant flow signifies benign or malignancy?
Malignant, madam.
So most of the times it is malignancy. So this is the slow flow, the newer modality. This is very useful for your smart diagnosis. So the vascular pattern. Please describe the vascular pattern. That is what you are telling now. So
Madam,
you please
here we can
interpret the
see
image A.
Only one vessel is there which is crossing the endomyometrial junction. This is called the dominant vessel. And it is like this single feeder vessel which is supply usually the polyp. And it can be branched or it can be unbranched also. Here it is branching. Single vessel with branching is seen in this second one. B picture.
Yes. C.
Here there are multiple vessels, but there is focal origin from the endomyometrial junction.
Okay. D.
And here there are multiple vessels, but there is multifocal origin of the vessels in the D picture.
Okay. Thank you. And E?
Here there are scattered vessels. They are usually seen in endometrial hyperplasia.
Okay. This one?
This one is a very significant of fibroid, where we are having peripheral blood flow.
This is called circular flow.
Circular flow, yes.
Then we'll move to enhanced ultrasound of the uterine cavity. And the contrast we use is normal saline or gel. It is called in many ways. So sonohysterography, saline sonography, or saline instilled sonohysterography. Okay, what are all the devices? Usually we use a 10 or 8 French Foley's catheter, an IUI cannula, or simply an infant feeding tube. But I prefer to use this SSG device because it has got a stillet so that the introduction will be easy and there is a stopper to prevent leakage from the external os. So it stops the fluid at the external os. I personally prefer this one, but you can use other things also. Okay, Dr. Sheetal. Sheetal is not there. Dr. Sheetal is not there. She's not there. Okay. Dr. Charu. Dr. Charu.
Manu,
Dr.
Charu. Yes, ma'am.
Yeah. Charu, can you take?
Yeah, again, this is a sagittal plane of the uterus showing heterogeneous type of.
Is it
uniform? It's uniform but heterogeneous.
It is heterogeneous.
Yes.
What about the central?
Central line is not properly visible.
It is not
defined. Yeah.
Then? Any sense?
Yeah, in the cavity there is a ill-defined lesion is there. Means the lesion is there, but the boundaries are not very clear. We cannot find any cyst.
Any fluid?
No fluid in the cavity.
Madam,
Any
one
lesion?
question, please.
Yes, yes.
Madam, if it is heterogeneous, then it should be non-uniform only.
No, no. Uniformity is the appearance. Heterogeneous is the architecture. Any lesion do you find?
Yes, there is a lesion, but it is ill-defined lesion. The
Yeah,
margins
yeah.
are not very clear.
So you suspect a lesion.
Yes.
I'm still having the echo.
Yeah, madam. Pardon?
The echo is coming. Voice.
Your voice is not clear, madam.
Anybody?
Charu ma'am, have you wear your headphones or something like that?
No, I don't have any other device. No headphones also.
Ma'am, somebody from the meeting has two devices on, or somebody has played the YouTube link in the background.
रेखा मैम आपके दो हैं आईडीज रेखा मैम आपके
नहीं no.
there are two रेखा वाधवानी
नहीं,
मैम
but I have closed that long back.
अच्छा but वो दिख रहा है मैडम
But not having, and my voice is also not echoing. There is some problem.
अब नहीं है अब now there is no echo.
Now there is no echo. Okay. So Dr. Charu, you still suspect an intracavitary lesion. Okay.
Yes.
Then I put mic. What is this? It is a pedicle artery.
This is a pedicle artery, and like most probably it is a polyp which is the artery is feeding is visible in the Doppler.
Yes. Then I put my fluid. What do you see?
Is it there's a mid cavitary lesion, and again most probably it's polyp only.
Okay. How do you describe the intracavitary lesion? What is an extended intracavitary lesion?
Miss, it is localized or not localized, whether we can define the margins or not. And
no. Don't describe it.
Yeah.
What is an extended intracavitary lesion?
If it is involving more than 25% of the endometrial cavity or surface, then it is a extended type of intracavitary lesion.
What is a localized?
Localized when it is not involving more than 25% of the endometrial surface, then it is a localized intracavitary lesion.
Okay. Next, who will take Manu, Dr. Manu?
Yes, ma'am.
Yeah. So please, this is a saline infusion sonography images. And how do you describe the surface of the lesion? How do you describe the surface?
Ma'am, it is heterogeneous with the
Surface of the lesion.
The lesion is heterogeneous. It is clearly defined with this saline, and there are few cystic spaces in the lesion.
Okay. Surface of the lesion?
It is regular.
Smooth.
It is regular and smooth.
What about this one? This one. The second image, B.
Irregular.
It is an irregular. So we have two. One is smooth surfaced polyp and an irregular surfaced polyp. So how do you measure? Please continue. Dr. Manu. Dr. Manu, how do you measure an intracavitary lesion? Who will take up this question?
May I? Ma'am, we will basically measure first at the base of near the endometrium base or transverse diameter at the base, and then that is A, and maximum transverse diameter of the polyp. That will be B. If A upon B is less than 1, then it is pedunculated polyp. And if it is more than 1, then it is sessile, and there are more chances of malignancy in the sessile polyp.
Yeah. This is how you measure the sessile polyp. It is more than 1. Okay, good. So coming to fibroid map. So when the fibroid is completely intracavitary with the pedicle, then it is 0.
100%.
When it is intracavitary, but less than 50% of the intramural extension, then it is type 1. It is intracavitary, but more than 50% is intramural, then it is type 2. So in this panel discussion, we'll discuss about 0, 1, 2, 3. So please interpret these images. Image A.
It is type 0.
Why?
Most of it is, almost 100% is in the cavity, ma'am.
Yeah, there is an attachment. It is also C. Okay. This one?
This
is
one more than 50%, so it is type 1.
This one?
less than
This
50%.
is, so type 2.
Type 2.
Okay. So I'll give you this polyp. So A is 0.6, B is 1.1, and A divided by B is 0.5. It is
Less than 1, so it is pedunculated polyp.
Okay, it is a pedunculated polyp. So I also use my OmniView and with VCI to show the pedicle. So this is smart diagnosis again. So who will take up this? Dr. Sunita? Dr. Sunita, madam?
Yes,
so
ma'am.
please watch this video and then we will interpret.
Okay.
I have given the sagittal view and also the axial view. Okay. Will you interpret? Is this uniform or non-uniform?
It is uniform.
How is the echo texture? Is it homo or hetero?
Heterogeneous.
Well,
And
central line?
central line is absent. We cannot see the central line.
Central line is there, but it is interrupted. It is seen here. It is seen a little bit here. Okay. It is an interrupted central line. Do you find any cyst?
Cyst is not there, ma'am.
Do you find any fluid?
Fluid is there in between the...
Yes. A little bit is there. So I have taken it as no fluid.
Okay.
So is there any intracavitary lesion?
Yeah, multiple lesions are there, ma'am.
Yes, multiple lesions are there. So this is the interrupted line.
Yes.
Then I have put color. So obviously there are multiple polyps and there are multiple feeder vessels. What is the score here?
4. 3.
3. Okay, it is 3. How many vessels? How do you describe this vascular pattern? One vessel is coming from here, from here, from here, from here.
Multifocal.
I think I can see 4 multifocal.
Multifocal.
Yes. Then I put fluid also to delineate. Can you count the polyps?
Yes, ma'am. 1, 2, 3, and 4. There are multiple polyps, ma'am. Almost 4 to 5.
Right. 4 are very clear. Fifth one is smaller.
Mostly on the posterior wall.
So please describe these polyps. So whenever we instill fluid, first we describe the surface and also the whether it is pedunculated or not.
It is a smooth uniform surface polyp.
Yeah.
Homogeneous with no cyst in the polyp.
Good.
Usually, most of the polyps are sessile, not pedunculated.
No, this is
Visually.
This is pedunculated. This is also pedunculated. These polyps are pedunculated. I'll show you the non-pedunculated one also. So this is
non-pedunculated.
Yeah, this is not non-pedunculated, sessile polyp. But those two are pedunculated. Okay. Can anyone can take this question? Who will take this?
Yes, ma'am.
Okay. You first watch the video. So the polyp is nicely moving along with the myometrial contractions. So this is called sliding sign.
Yes.
What does it imply?
Basically, when we are unable to see the endometrial interface.
It is clearly seen. Interface is
seen, yes.
Bright edge echo sign is positive. But I am talking about the sliding sign. What does it imply? Why should a polyp slide?
Freely mobile inside the uterine endometrial cavity.
That means
not attached to any of the surfaces.
That is pedunculated.
Pedunculated 100% in the cavity.
Yeah, I put my color. It is also showing pedicle artery sign.
Yes.
This is the 4D image. This is what about the bright edge sign. Polyp is crystal clearly delineated. You can see all the endomyojunction intact. And again, I have put my color. So this is a unicornate uterus with pedunculated polyp. And now the drama begins. I use all my smart tools. Magic Cut, Edit Light, all those things.
Very nice.
So cool. This is smart diagnosis. Do you accept?
Yes,
do you
ma'am, sure.
do you require any hysteroscope to diagnose this?
No.
Yeah. What is this called? This is called sonohysteroscopy.
So, ma'am, in the sonohysteroscopy, you are putting a virtual sort of fluid. There is no fluid. You're just doing with the help of this thing, your smart
Saline
devices, no?
infusion. No, I have put saline infusion. It is
You
infused.
have put I thought you were doing with the Magic Cut and you're creating contrast.
Magic Cut is for you to see the image. It is only for the sake of the image. It is only for the sake of image.
Okay, ma'am.
To have the image, a beautiful image, I put the Magic Color, a Magic Cut. Okay, coming to endometrial hyperplasia. So there is a difference of opinion, but I put it like this: more than 14 millimeters in premenopausal and more than 4 millimeters in postmenopausal with intact endomyojunction. Okay, who will take up this question?
Yes, ma'am.
Yes, Manu, Dr. Manu.
Yes.
Please describe this.
Ma'am, this endometrium is heterogeneous.
Is it uniform or non-uniform?
It is non-uniform.
It is uniformly enlarged.
It is uniform.
It is uniformly enlarged, both the layers.
It is uniformly enlarged, heterogeneous with cystic areas in the
What about the
endometrium.
central line? What about the
Central line is interrupted.
It is not interrupted. It is wavy. It is wavy.
Okay, ma'am.
But it is non-linear.
It is non-linear.
It has cysts. Yes, good. Irregular cysts. The cysts
It
are
has
irregular,
irregular
right?
cysts.
It is a large cyst. Here are small ones. Here again big cysts. So there are irregular cysts. Okay. Is there any fluid?
No fluid is there.
Do you find any intracavitary lesion?
No lesion is there.
Yes, no lesion is there. How do you, what could be, do you do a biopsy for this? Definitely you'll do a
We
biopsy.
should do biopsy for this.
What could be the histopathology report? What do you expect the histopathology report to be with this image? If image is like this, what do you expect the
I
histopathology?
expect a simple hyperplasia, cystic hyperplasia.
Good. What are the cysts? What does the cyst imply? We have glands and stroma in the endometrium. These cysts are glandular. So this is cystic glandular hyperplasia.
Cystic glandular.
Do you agree?
Yes, ma'am.
Yes. Can I tell you what the histology report is? It is cystic glandular hyperplasia.
Yes.
Okay. Now you are a sonopathologist, right? You don't require a pathologist also when you do this type of sonography. Okay.
Ma'am, what is the color flow in that lesion?
It is scattered, not very much.
Okay.
Yes.
Ma'am, if the same lesion is there, suggestive of cystic glandular hyperplasia, but you see chaotic vessels grade 3, grade 4.
So then it could be a malignancy.
Yeah.
So please interpret this image.
Hello. Shall I take this?
Please interpret.
Yeah. Actually, this is a heterogeneous type of endometrium because the lining is homogeneous.
Uniform or not?
It's not uniform.
Not uniform, ma'am.
Central line is not visible.
It is heterogeneous.
It's heterogeneous.
What did you say?
Central line is not visible.
Is it homo or hetero?
It's homogeneous.
Yes, homogeneous.
But the thickness is very much, and we cannot see any cyst also.
No cyst. Fluid.
No fluid in the cavity. No lesion in the cavity as such. It's homogeneously enlarged endometrium.
What do you think the histology could be?
We don't see any cyst. Yeah, we cannot see any cyst.
Glandular.
Glandular.
What could be
What
this?
could be this?
Stromal hyperplasia
Yes.
may be there.
Yes.
So I've done a
I've done a
band and the
and the
histopathological endometrial
endometrial
stromal
stromal
hyperplasia
hyperplasia
and no
and no
ATP.
ATP.
So what is
So
this
what
called?
is this called?
This is called
This is called
sonopathology.
sonopathology.
Do you accept?
Do you accept?
Yes, ma'am. You are a very good teacher, madam.
No, no.
No, no.
You are a
You are a
very good interpreter. So I derived the diagnosis from you only, your interpretation. Okay. Anyone can take this. It is a case of postmenopausal bleeding. Who will take this? Sunita? Dr. Sunita? Dr. Sunita?
Yeah. Yes, ma'am.
Yeah, first you watch this video. This is a case of postmenopausal bleeding. Okay?
Yes, ma'am.
Yeah. Please
The
interpret.
outline is uniform, ma'am.
Yes.
It is heterogeneous.
Ah.
Cystic lesions are present. Sorry, central line is present and can be seen.
Yes. Central line is seen. It is only seen up to here only.
Yeah.
Here
But
also it is
interrupted, but it is seen.
Okay.
And, the cystic lesions are there. Cystic lesions are there.
Yes.
And
Fluid?
Fluid is not present, ma'am.
Okay. Any lesion?
A lesion at the fundus, I can see a lesion, but I'm not very sure about.
You see a lesion here. Huh? What do you think of? You do find any bright edge echo? I don't think so.
No,
Anybody
madam.
can find a bright edge echo in this image?
No, ma'am.
So it seems to be an endometrial hyperplasia. Yes. Everybody agreed?
Yes, ma'am.
Okay, we'll see what happens. So this is again I have put still images. This patient is also having a fibroid. So then I put my color. You seem to be correct, Dr. Sunita. There are feeder vessels. So it might be a lesion also. How can we diagnose it or confirm it? Then I'll put my
fluid.
Saline can be still done.
Yeah, what is there?
It is a lesion, ma'am. It is a polyp.
It is a large endometrial polyp.
Yes, ma'am.
Heterogeneous polyp with cysts. It's a large polyp.
Yes.
And most likely to be malignant.
Do you think it's malignant?
Can't say.
It can be because it is.
It has only 2 feeder vessels.
But still, it is postmenopausal, ma'am.
That's what. Who has told? Dr. Sheshadri has told that 90% of the polyps in the postmenopausal are benign.
Benign.
Yes. Because how can you say that it's a benign?
Smooth
The
surface.
surface is smooth.
Yes.
And there are only 2 feeder vessels. There is no branching for the vessels also. So it's a large pedunculated endometrial polyp with smooth surface, and histopathology gave this as a benign polyp. So this is again sonopathology. You all become sonopathologists today. So images are deceptive sometimes. So we need more than one modality for the confirmation. Okay. Anybody can take up this question? This image, please interpret this image. Dr. Sunita?
This is a uniform outline. It is homogeneous.
Good.
Central line cannot be seen very clearly.
There's no central line.
Yeah. And no cystic areas are present.
Okay.
And
Fluid?
No fluid in the endometrial cavity.
Any lesion?
No lesion seen per se.
Yes. But in this image, you don't see any lesion. Do you suspect any lesion from this image?
Yes, ma'am, there might be in the middle.
Can be there.
No, that is not. Do you suspect any lesion from this image? Yes or no?
No.
Yes. Okay. Accept.
Ma'am, there's a thickening in the center, no?
Yeah, it can be there also for stromal hyperplasia. Now what is there? I put my color. There is a feeder vessel. Okay?
Yes.
It might be a polyp.
Yes, ma'am.
Then I put my fluid.
Yes.
We'll find a polyp. Okay?
We really got enlightened today, ma'am, with your talk.
Yes, ma'am. We were very worried about your panel.
No. You're all interpreting very well. That's it.
We are really getting, I mean, like,
Yes, we are not getting anything from your side, but
Madam,
Okay.
actually, Jaya, madam, your panel is a very good,
Yeah,
thing
that
to
is what.
associate with Adi madam's lecture. After the
Yeah.
lecture, this panel is like very suitable.
I will give
Everybody is
credit to the
enjoying.
madam only because she is teaching so nicely, We are also learning.
No,
from
no,
her.
no. I don't accept that. You're interpreting so nicely.
So,
So
Jaya,
this is
madam,
one
so
more case. This is
ma'am,
one more case.
whenever you see an endometrial pathology, you always instill fluid?
No inflammatory pathology. Whenever I
No, no.
suspect a lesion,
Okay.
whenever I
Whenever
suspect
you,
a lesion, even though I don't require it for diagnosis, I instill fluid to know the attachment, whether it is pedunculated or non-pedunculated, whether it's smooth surface or irregular surface. I always put fluid before my hysteroscopy.
Ma'am, patient must be in a lithotomy position for installation of fluid.
Yeah, same. How I do your IUI. That is what I have shown the IUI catheter also. So
madam,
this
what
is one
about
more
adhesions?
case.
If you suspect adhesions, you put fluid, madam?
Not many times.
Okay.
Not many times. I don't have many cases also. That's why I'm not included addition case this.
Okay,
So
ma'am.
this is one more case. This is simple B mode image. What do you see here?
Ma'am, lesions are seen.
Yes.
It's an
No
outline
central
is
line.
uniform outline, heterogeneous. Central line is not seen. It
Yes.
has no cystic lesion seen, no fluid seen. And
You
from
see?
this 2D image, we can see it has multiple lesions.
Probably 2 polyps, not multiple. Because here brighted Jaco is seen. So these are 2 polyps. This is
Yes.
only a B mode image. So
Yes.
I'll give you the 4D. You see the 4D. So now I answered Dr. Monica your question without fluid. So without fluid also you can diagnose this VCIA. This is 4D mode. So the 2 polyps are crystal clearly seen, right? Do you appreciate? I'll play it again. There are 2 polyps without fluid. You can crystal clearly see those in 4D image. Okay?
Yes.
So sometimes you don't require any fluid also. So this is one more case. Who will take up this? Who will take up?
Everybody is an expert now.
Yeah. Anybody can take this. Who will take up this?
Dr. Rekha.
Yes, ma'am.
Yeah. Please take up this question. What is this image? Mom?
Ma'am, this is not uniform
Yes.
and it is heterogeneous
Okay.
and central line is not clearly visible
Yes.
in this case.
Mm.
And lesion is there.
Yes. A cystic lesion?
Yes, cyst is also there. Cystic lesions are there.
Okay. In this case, I have not put any fluid. Then you see, I have put the color. What do you see?
It is multifocal.
It is, no, it is not multifocal. It is bifocal.
Yes,
One
from
vessel
here.
is coming from above and one
Yes.
vessel is coming from below, but these vessels are interrupted here. We see 2 feeder vessels. So maybe this can be a 1 polyp or 2 polyps because it is showing 2 feeder vessels. We'll see what happens. The drama.
Yes, now it is clearly seen.
2 polyps.
2
crystal
polyps,
clearly
yes.
seen. This
Very
is
nice.
drama. This is drama. I'm using my walkthrough button. This is my walkthrough button.
Very beautiful. Very beautiful.
Do you require any hysteroscopy?
No, ma'am.
What
To
machine
remove
are you
them.
This is E8.
What machine is this?
Oluzen E8.
E8. Okay.
You can do this with any machine, any upgraded version. Anything can give it. That is what you should know the machine first.
No, madam, E series is different. E series is nice.
No, you can do this in other series also.
No, ma'am, the 3D imaging is not very good in other
No,
bodies.
no, no. You have to do the settings. So this is, I don't do hysteroscopy. I do only sonohysteroscopy. So from tomorrow, Monday onwards, you can also do sonohysteroscopy, sonopathology.
Jaya madam, your next talk will be on 4D. I've already thought of the next talk.
We'll see, we'll see. Okay. This
Ma'am,
is
this
one more.
photo,
of
histography which you do, ma'am, you do with IUI cannula, ma'am, or Foley's?
No, no, I do with my SSG device. I have shown that SSG device.
Yeah.
Hmm.
It's
Okay,
a, it's
okay.
a, I've
So
taken
this
a
is one more
screenshot.
case, one more case.
Uniform outline.
You first completely watch the video. So definitely there is a lesion. Everybody will accept it.
Yes.
And
Is
it's
there
got
any
some,
difference? Is there any difference?
it's got a bright interface also.
So this intercapillary lesion is seen only towards one side because on the other side you'll see the 3-layer pattern. Now you watch. You see the 3-layer pattern. So this is it. This is it. The 3-layer pattern is seen towards one end. On the other end, the polyp is seen. So that means it is incompletely filling the cavity. Okay, we'll see. We'll proceed to the next thing. I put my color. How do you interpret this? What is the score?
Multiple feeder vessels.
So these are not the vessels. We are not interested in these vessels. These are myometrial vascularity. Please interpret this one only.
Score
Color
is 4.
Score is
4.
3.
3 is bottom.
It is 3. Okay. Then I put my fluid. You see, the polyp is towards only one wall. That is why on the other side you see the 3-layer pattern.
Okay.
Is it a pedunculated or sessile polyp?
And pedunculated, it is pedunculated less than 1.
No, it is sessile.
Sessile,
Almost
okay. Yes,
both
ma'am. Yes.
Same. Both are same. A and B almost same.
Same. Okay.
So then drama begins. So the same vessels. Then the drama. HD light, edit light with little bit of magic cut. All other modalities of 4D. Okay, that finishes it. Then this is second case of postmenopausal bleeding. Who will interpret this?
Yes, ma'am.
Okay, Manu. Yes, very good. Come on.
Ma'am,
First
endometrium
watch, you
is
please watch the video. There is also a fibroid, you see? Shall I play it again?
Yes, ma'am.
Yes.
This is the fibroid. There's not breach of endomyojunction. It's a fibroid.
Okay.
Then you interpret. You interpret the image.
Ma'am, the endometrium is not uniform.
Yes.
It is heterogeneous.
Good. Central line?
Not visible.
Central line.
There is no fluid in it.
A little bit of fluid is there here and there. Okay, you can say no fluid.
No central line is there.
Central line is virtually absent.
No central line is there. And there are few cystic spaces.
You think these are cystic spaces?
Yes, ma'am.
Okay, accepted. But basically it is hyperechoic.
Yes.
Yes, it is hyperechoic.
Then I'll give you the 4D for irregular surface. Without fluid, I am showing the irregular surface. Do you accept it?
Yes, ma'am.
Yes.
It is irregular.
Irregular system. Irregular surface signifies malignancy.
Malignancy.
Anyway, it's a case of postmenopausal bleeding. Okay, I have put my color. What is the score?
Four, grade 4.
4.
Yeah.
Chaotic.
This is power Doppler and this is slow flow. Chaotic, irregular, immense color, 4. Then I immediately put my 4D glass body mode and you see. I have extracted all the vessels. Well, this is cine volume. I extracted all the vessels.
Loaded with blood.
Yes, loaded with vessels. Chaotic branching. How nicely it is seen. Okay, the biopsy shows it's a CA endometrium. Okay, this is again a case of postmenopausal bleeding. Anybody can take this.
Adenomyosis.
No, postmenopausal bleeding. It is endometrial lesion only, not adenomyosis. Okay, we'll take up this. You can see endometrium here, and you can see this intracavitary mass. What do you think this mass could be? The
Ma'am, there's a
echogenicity
breach
is
of the
similar.
endomyometrial junction. Endomyometrial junction.
Yes.
Yeah.
Echogenicity is similar to myometrium.
Isoechoic, right?
More towards fibroid.
Yeah, I have put my fluid.
Yes.
Okay. How do you grade this Figo stage?
Figo stage
0.
3.
Not 0. It is not pedunculate.
3.
3
More
doesn't.
We
have only 0, 1, 2 for this.
No, ma'am, 2. I'm sorry, 2.
This
It is
is the fibroid.
1.
2.
This is
1. More than 50% is
in the cavity, yes.
Less than 50%. This is less than 50% inside the myometrium. It is type 1. I don't have the histopathology because I lost this patient. So this is one more case. This is the static image and you see the video. There's an irregular mass in the endometrial cavity.
This was the saline you had infused?
No, it is having fluid.
And will this be polypoid endometrium?
No, this is quite heterogeneous.
It is heterogeneous, having lot of fluid, irregular surface.
She's postmenopausal, ma'am.
No central line.
She's not postmenopausal. It is not like the previous ones I have shown you, right? You agree?
Yeah.
It doesn't fit into the category of images so far we have seen.
Yes, ma'am.
It looks different. I was so puzzled. So I put my color. Right,
yeah.
RPOC, ma'am?
Yeah, congratulations.
Congratulations.
Congratulations. There's no color.
Yes.
How can such a big mass having no color? It should have vessels if it is abnormal, but it is not having color. So when we insisted for the history, finally patient revealed that she had an abortion 4 weeks back. It is a case of RPOC.
RPOC.
Congratulations for your diagnosis. So we'll come to some miscellaneous things. It's a case of postmenopausal bleeding.
Biometra.
Yes. Please interpret the image before the diagnosis. First image interpretation and then probable diagnosis. And finally pathology.
Uniform margin, heterogeneous margin. I mean, no central line, no cystic areas.
Low level echos are seen here.
Echogenic low.
Echogenic fluid is there.
Ground glass appearance.
Do you observe anything in the cervix? So this is correct, and you observe the cervix.
There's dilatation and
If the cervix is dilated, how can you have the fluid?
No, ma'am.
There is a cervical growth, heterogeneous growth.
Yes, there is a heterogeneous growth with the specks of calcification.
Calcification.
So this is a case of
Advanced.
infiltrating CS cervix.
Yes,
Because
cervix.
on per speculum, we don't find the cervix looked normal. Surprisingly, it was a case of infiltrative cervical carcinoma.
With
It has
pyometra.
blocked the internal os. So that's why she had the pyometra and postmenopausal bleeding.
What was the pouch of Douglas like in this case?
Looks normal only. You can see in the image. So it looks
Yeah.
normal only.
There's fluid in the pouch. Yeah.
There's no fluid.
The ovary
No
is there,
fluid.
ma'am.
Yes,
No,
it
means
is.
it's a normal sort of fluid. Normal. Means the rectum is spared, no, ma'am? As per our findings, the rectum is not.
You see the layers of the rectum also.
Yeah.
Crystal clearly say, oh, it should be an early infiltrative. It has not spread into the pelvic organs. Okay. So this is one more case of postmenopausal bleeding. I am coming to end of my presentation. Only 2 or 3 slides are left. See the video. There's already some fluid. We will interpret this. This is not saline infusion.
Irregular margins, ma'am.
What? Regular?
Irregular margin. Heterogeneous. Fluid is present. Central line absent. No cystic areas. Scattered flow of blood vessels.
I'll show you the video. What is the score?
Focal. 3.
Four. Lot of blood is there.
Chaotic.
Yeah. And branching is more important. It is
branching.
Irregular chaotic branching.
Branching, yes.
So I have extracted all the vessels again.
Ma'am, here the source of color flow seems to be at one focus, no, ma'am? When you showed us the...
See the other side. The other side.
Yeah.
Yeah,
like
you are correct. You are
it's like
correct.
a fountain
It's coming
coming
from the
from
other
one side.
Other side also.
Branching, but from the same focus. It is from only one focus.
Yeah. So,
Of
ma'am,
this
malignant growths also have a point where maximum vascularity arises.
Yeah, that is it. It is an endometrial polyp. It's a malignant endometrial polyp.
Malignant polyp, yes.
You see the video again. Yeah, you see this video. It is a malignant endometrial polyp. That is why you see focal vessels.
Ma'am, where is it attached? Fundus?
Most probably this one. Because fluid is separating only lower down and posteriorly.
Yeah, this is the place. The 11 o'clock position is the maximum vessels, 11 to 12.
Okay.
Mm.
So this is again one more case of postmenopausal bleeding. There's a huge mass. It looks lobulated with irregular margins, cis, hyperechoic.
Central line not seen, no fluid.
It's a huge mass. You can't see the center.
Lobulated with a smooth surface, actually. The surface is not very irregular, madam. That is why the
Not very irregular, but it is irregular.
Lobulated, sort of.
Yeah. What is most important of this? Endomyojunction looks very intact. It is
very
surprising.
intact, very intact. Yes.
That is surprising. Then you see the color flow again. 4.
Chaotic.
4, score 4.
Like EVMM enhanced myometrial vascularity.
Then I'll give you the
Yeah.
coronal image. You see the irregular lobulations with intact endomyojunction.
Yes.
But color?
4.
Even more than the previous ones.
Yes.
But here you see this focal origin. I'll play again.
Malignant, ma'am.
Yeah. Focal origin. Focal origin.
Polyp, malignant polyp.
Yes.
Malignant polyp.
Malignant endometrial polyp. So this is only for completion's sake. Copper T. This is a Marina. That is a multilode. This is the Marina and Emily. So finally we'll come to the end. So the take-home message, I'll give you the Panchasutra mantra for smart diagnosis of endometrial pathology. Start with TAS always. TVS is the gold standard. Doppler is the key. Use sonohysterography and transrectal ultrasound liberally. And finally, of course, it should be the first thing. Know your machine first. Unless you know your machine completely, you can't do any smart diagnosis. Do you all accept with me this statement?
Yes, ma'am.
Yes, ma'am. Totally.
Yes,
Tomorrow,
ma'am.
tomorrow we are all going to celebrate Mahashivratri.
Happy Shivratri.
Lord Shiva has third eye. For all clinicians, USG is the third eye.
Yes, madam.
Yeah.
Very nice, ma'am.
I'll just play this 2-minute video. Compilation of all the images, what I have shown you.
I think this is the video which was shared, no?
Yeah, yeah.
Yeah, she's showing.
So Doppler settings are very, very important. You should learn those things. Unless you do Doppler settings, it will not work in your hands. VCI is a very useful tool. You practice using it in your daily practice.
Ma'am, how to use VCI?
It is there. The button is there on the screen.
Yeah.
VCIA.
VCI will make the slices, madam? No.
No. Volume contrast imaging.
Volume contrast. Yeah. Okay.
You can use it with OmniView with VCI and with your 4D also. So finally, I conclude that the TVS probe is the third eye of the clinician. Thank you. Thank you very
so much,
much.
ma'am. You truly said I really enjoyed a lot.
Really, very nice presentation.
Very nice, very nice.
Dr. Monica, I think I have stood up to your expectations.
Yes, madam.
Thank you, ma'am.
Yeah.
I will share a little story with all of you. A couple of months back, Dr. Jaya was a panelist in a panel which was done by moderator Dr. Jayashree Sridhar from Indore. So I think, madam, it was some infertility panel. Doppler, yeah. So there it was so fast and rapid. So after the panel, Jaya madam gave me some suggestions that Monica, it should be like this, it should be like this. Monica, madam, you will be my next moderator only. So, and madam is so dedicated and so soft spoken and such a nice teacher. I really feel humbled to listen to, and we are listening from comfort of our homes. We are learning such a lot.
Thank all the participants.
No, ma'am, we were anxious, but we thoroughly enjoyed the panel.
And madam,
Thank you so much.
we never listen with so much, concentration in conference. In conferences, we are tired, sometimes
The whole
puzzled.
day you can't listen.
It was classroom teaching only, hand holding rather.
And remember, all these lectures are recorded on YouTube, so you can watch them again and again and again whenever you want. And they are available for you to see. So thank you so much, Jaya madam. I'll be troubling you more often.
Yeah, sure.
Thank you,
very
Monica,
much.
also for giving this opportunity.
Thank you, Rekha ma'am. Thank you so much, and thank you to all the panelists. Thank you, Rhea
Thank
ma'am.
you, Monica ma'am, for
Dr.
inviting me.
Supriya ma'am is there? Is she
Supriya ma'am
there
is
or she left?
yeah.
Dr. Supriya ma'am?
Ma'am, her name is there on the board panel, but I don't know whether she's there or not.
Okay.
And of course, Dipti ma'am, for your wonderful inputs. Upma madam, for your enthusiastic participation. All the panelists were just wonderful. Manila, you are there. And you have
Yes,
done
ma'am. I'm there. I'm sorry. I was listening to the viewers link. I didn't knew कि मैं faculty भी हूँ. So मजा आ गया. मतलब आज का panel तो was nothing like that, ma'am. I'm mesmerized. मतलब I would share this to so many of my students now. I mean, it was wonderful, wonderful.
So yes, we take leave from Synergy 24, me and my team. We are on the Silver Jubilee of Synergy now. Synergy 25 is a Silver Jubilee episode. This is on 25th of February, Wednesday. And we are dealing with congenital anomalies in fetus which are visible on ultrasound. I have a special soft corner for ultrasound. So you will see very lot of sonography in my webinars. And I try to learn from the teachers because I'm nothing. I just get the best teachers here so that we can learn together. So thank you so much. Thank you to INTAS. Thank you to all the speakers. Thank you to all the societies. Thank you.
Thank you, ma'am. Thank you. Thank you.
Now you can all celebrate Valentine's Day and Mahashivratri.
Thank you.
so much. Thank you. Good night. Thank you, Vishal. Thank you,
Thank you,
INTAS.
ma'am.
Thank you.